Welcome, curious minds, to the deep dive. Today we're plunging into a topic that, well, it affects millions, yet often remains shrouded in complex medical jargon.
Hmm.
I'm talking about something that the World Health Organization confirmed as recently as 2020 as the #1 cause of death globally: cardiovascular disease.
It's a staggering number.
It really is. A staggering reality, not just a medical term, but a profound global health challenge impacting millions. And at the heart of much of that challenge is a condition called dyslipidemia.
That's right. And what sounds like a bit of a mouthful, dyslipidemia,
Uh-huh.
is fundamentally a disorder of how our bodies manage fats, lipids in the blood.
Okay.
It's an imbalance, really. You have either an overproduction or sometimes a deficiency of these crucial lipoproteins, those tiny fat-carrying particles essential for moving lipids around.
Right.
Understanding this imbalance is truly critical, especially given that global burden of cardiovascular disease we just mentioned.
Absolutely. Our mission today, then, is to give you a shortcut to make you truly well-informed about dyslipidemia.
Yeah, get you up to speed.
Exactly. From its fundamental biology, the intricate dance of fats and proteins in your bloodstream, all the way to the latest therapeutic strategies. We're going to unpack this intricate topic, maybe reveal some surprising facts along the way,
Definitely some of those.
and provide you with the insights you need to grasp it like an elite professional in the field.
And to achieve that depth, we've based this deep dive on some really comprehensive, authoritative source material, specifically excerpts from GOODMAN and GILMAN's The Pharmacology.
The gold standard.
Pretty much. So this isn't just a surface-level overview. We're going straight to the scientific core to give you a robust foundational understanding.
Okay, let's unpack this. So we've introduced dyslipidemia, but let's really nail down its core definition and its profound impact. When we talk about dyslipidemia, what are we really talking about?
Right. At its core, it's a disorder in how your body processes and manages these lipoproteins. In simpler terms, it's an imbalance in the amount or type of fats, lipids in your blood.
An imbalance. Okay.
Yeah. And this can be caused by your body either producing too many of certain lipoproteins or maybe not enough of others that you really need. It goes both ways.
And the consequences are, I imagine, pretty significant.
Oh, far-reaching and incredibly serious. Dyslipidemia isn't just, an isolated issue on a lab report.
Right.
It's directly linked to atherosclerotic cardiovascular disease, which we often just call ASCVD. But it also significantly contributes to ischemic cerebrovascular disease that affects blood flow to the brain, think strokes, and peripheral vascular disease, which impacts circulation in your limbs. These aren't just conditions, they're major drivers of the illness and, unfortunately, the mortality we see worldwide.
It really puts that alarming statistic from the WHO in 2020 into perspective, doesn't it? Cardiovascular disease truly is the #1 cause of death globally.
It really does.
That statistic underscores just how absolutely critical it is to understand something like dyslipidemia because it sits right at the very heart of this massive global health challenge.
Precisely. And the culprits behind these lipid imbalances, they're varied. It's not always one thing.
Okay.
They can stem from genetic disorders where there's an inherited predisposition. Your body is just wired differently, in how it handles fats.
Right. It runs in the family.
Exactly. Or they can arise from metabolic diseases, with diabetes, mellitus being a prime example. Lipid metabolism often goes awry there because of how the body processes sugar and insulin.
Makes sense.
And of course, lifestyle factors play a huge, undeniable role. We often see dyslipidemia manifest as hypercholesterolemia. That's simply high cholesterol, but also unhelpfully low levels of high-density lipoprotein, or HDL.
Cholesterol?
The good cholesterol.
That's what many people call it, yeah. The good cholesterol.
So if the core problem is this imbalance of these fat packages, how has the medical community evolved in trying to manage it? It seems like cholesterol management guidelines have seen some pretty significant shifts over time, almost like watching a medical philosophy evolve. It's a fascinating journey, actually.
Yeah.
If we look back, say, to 2004, the Adult Treatment Panel of the Third, or ATPIK, had its own established approach. They often set very specific LDL-C goals for patients, like hit this number.
Right. Very target-driven.
Very target-driven. Then, around 2014, the American College of Cardiology and American Heart Association, the ACHA, they published new guidelines that introduced a notable shift.
Okay. What changed?
They emphasized fixed-dose statin recommendations. especially for patients who had already had a cardiovascular event that's secondary prevention and for patients with diabetes.
So less about the specific number and more about the drug intensity.
Exactly. The idea was to put more focus on the intensity of statin therapy rather than chasing a specific numerical target for absolutely everyone.
But then came the 2018 AAACC cholesterol guidelines, and this is where it gets really interesting from what I understand. They sort of circled back.
They did, in a way. They signaled a sort of return to earlier approaches by reintroducing cholesterol percent reduction targets for specific high-risk groups, especially in primary prevention, preventing that first heart attack or stroke.
So aiming for a percentage drop rather than a fixed number again.
Yeah, for certain groups, it almost feels like a merger of different schools of thought. It pulled from both the fixed dose intensity approach and the percentage reduction goals of previous guidelines. Our source material actually lays this out quite nicely, showing how these different recommendations sort of coalesced over time.
A hybrid approach, almost.
Kind of, yeah. And the field keeps refining itself. Since 2018, we've had further updates, like the 2019 ACHE guideline on primary prevention. Those specifically went deeper into considerations for aspirin use and provided much more detailed non-pharmacological recommendations for preventing ASCVD. So it's clearly not a static field.
So what's the practical impact for doctors and patients today? How do these changes affect how cholesterol is managed now?
Well, the big practical implication is a move away from those rigid one-size-fits-all cholesterol goals towards a more individualized, risk-based approach.
More personalized.
Exactly. Now, it's often about achieving specific percentage reductions in LDL-C depending on the patient's overall risk profile. It really encourages, critical thinking about how to best manage each person rather than just hitting a number across the board.
All right, let's dive even deeper then into the microscopic world within us. To truly get a handle on dyslipidemia, we need to understand this intricate world of plasma lipoprotein metabolism. At the core of it all are the lipoproteins themselves. What exactly are they made of, and how are they structured to do their job?
Okay, sure. Lipoproteins are fascinating. Macromolecular assemblies. Think of them as tiny, highly organized transport vehicles.
Those shuttles.
Yeah, they're essentially little spheres. Their main cargo includes different types of fats, free cholesterol, which is unesterified, and cholesterol esters, which are esterified and therefore more water insoluble. They also carry triglycerides and phospholipids.
So how are they structured? Like, what holds them together?
Structurally, imagine that tiny spherical shuttle. The outer shell is made up of the free cholesterol and the phospholipids. This creates a boundary that can face the watery environment of your blood.
Okay. And then there are the special proteins you mentioned, the apolipoproteins.
Exactly. Often just called apoproteins.
Yeah.
And they're absolutely crucial. They provide structural stability to these little spheres, stopping them from just falling apart as they travel through the bloodstream.
Just holding it all together.
Yeah. But they do more than that. They have really multifaceted roles. They function as specific recognition signals, acting like keys that fit into particular locks on cell surfaces, allowing the lipoproteins to dock and deliver their cargo.
Smart.
And they also act as cofactors in enzymatic processes, basically helping enzymes do their job in regulating the entire lipoprotein metabolism system. It's quite complex. Our source highlights tables that detail the major classes and their properties and the specific roles of these apoproteins.
So these are incredibly complex and precise structures. What happens if there's even a tiny glitch, say a mutation in one of these components?
That's a great question, and it highlights their importance. Even small genetic mutations in these lipoproteins or their corresponding receptors can lead to what we call familial dyslipidemias.
The inherited forms.
Exactly. And tragically, these often result in premature death due to accelerated atherosclerosis, that plaque buildup in the arteries. It really underscores the critical importance of their precise structure and function.
Wow.
Inside these spherical lipoproteins, the most water-insoluble fats, like those cholesterol esters and triglycerides, form the central core.
Hiding from the water.
Right. While the more polar water-soluble components, the apoproteins, phospholipids, and the unesterified cholesterol are on the surface, facing the watery plasma. Many of these apoproteins have unique structures that let them interact with both the fats inside and the water outside, determining their specific jobs.
That makes perfect sense. They're like specialized messengers, each with a unique address label and a specific task. Now let's talk about their journey. Our source material points to two main pathways. First, the uptake and transport of dietary fat and cholesterol.
Right from the intestines?
Shown in figure 37-1, and then the reverse cholesterol pathway in figure 37-2, which sounds fascinating, like a recycling program.
It really is like a recycling program. Let's start with that first journey, the one dealing with dietary fat absorption and transport. This is primarily carried out by chylomicrons.
Chylomicrons, these are the big, bulky transporters of the lipoprotein world, right? The heavy lifters.
They are indeed. The very first step, actually absorbing cholesterol from your food in the intestine, is handled by a specific protein called Niemann-Pick C1-like 1.
Okay.
And this is significant because this particular protein seems to be the target for ezetimibe, one of the cholesterol absorption inhibitor drugs we might discuss later.
Ah, okay. Drug target.
Exactly. So after the cells lining your small intestine take up these dietary fats and cholesterol, the lipids get packaged up with a newly made protein, ApoB48, to form the chylomicrons.
And ApoB48 is unique to them.
Yes, ApoB48 is quite unique. It's made only in the intestine and primarily acts as a structural component for chylomicrons. These completed chylomicrons are then released. And yes, as you said, they are the largest and lowest density plasma lipoproteins. After a fatty meal, you'll find them circulating in your plasma for about 3 to 6 hours.
So they absorb the fat, package it up. Then what? Where do they go from the intestine?
From the intestine, they don't go straight into the blood. They enter the systemic circulation via a lymphatic vessel called the thoracic duct.
Okay, interesting route.
It is. Once they're in the bloodstream, their main cargo, the triglycerides, gets broken down into free fatty acids by an enzyme called lipoprotein lipase, or LPL.
Oh, LPL. Good.
This happens right at the surface of tiny blood vessels, the capillaries, in tissues that need energy or need to store fat, like adipose tissue, skeletal muscle, heart muscle, and even breast tissue during lactation.
So LPL kind of unloads the cargo.
Exactly. It frees up the fatty acids, which are then taken up and used by those tissues.
Right.
A crucial detail here is that this interaction between chylomicrons and LPL requires another helper protein, apoC-TI, to work properly.
Okay, apoC-TI is the helper. That brings us to chylomicron remnants, I suppose, the leftovers.
That's right.
They still contain all the dietary cholesterol, but without most of the triglycerides.
Precisely. When LPL has done its job removing much of the dietary triglycerides from the chylomicrons, what's left are these chylomicron remnants. They detach from the capillary surface and are very quickly removed from circulation by the liver, typically within minutes.
Wow, that's fast. How does the liver grab them so quickly?
It's a two-step process, mainly. First, they get kind of trapped or sequestered by certain proteins on the surface of the liver cells, the hepatocytes. Then they're processed further by another enzyme called hepatic lipase, or HL, which trims down the remaining triglyceride content even more.
HL, okay.
Finally, a protein called ApoE acts like a key, helping the liver take up these remnants by interacting with either the liver's main LDL receptor or another related receptor protein called LRP. It's a really efficient system for clearing out that dietary cholesterol.
And I remember you mentioning earlier that the shedding of certain components during this breakdown actually helps create nascent HDL.
Yes, that's another important byproduct. During the breakdown of chylomicron triglycerides by LPL, certain proteins like ApoAI and also phospholipids are shed from the chylomicron surface and remain in the plasma.
Yep.
This is one of the ways that nascent or precursor HDL is generated. Now, here's a crucial point to understand. Chylomicron remnants are not direct precursors of LDL cholesterol.
Ah, okay, so they don't turn into LDL.
No, they don't. However, the dietary cholesterol they deliver to the liver does indirectly affect your plasma LDL-C levels.
How so?
Well, when there's increased cholesterol delivered to the liver, it can suppress the liver's production of a protein called PCSK9.
PCSK9. I feel like we'll hear more about that later.
We definitely will. But reducing PCSK9 is generally a good thing for LDL levels because less PCSK9 means the liver's LDL receptors stick around longer and work more effectively. This actually reduces LDL receptor-mediated breakdown of LDL, meaning LDL is cleared more slowly from the blood, raising LDL levels. Wait, let me rephrase that. Increased liver cholesterol suppresses PCSK9 expression, which in turn reduces LDL receptor-mediated catabolism of LDL. My apologies, that was confusing. More cholesterol suppresses PCSK9. Less PCSK9 means fewer LDL receptors are degraded. More receptors clear LDL faster, thus lowering plasma LDL.
Okay, got it. More dietary cholesterol. Less PCSK9, more LDL receptors, working lower plasma LDL. That's counterintuitive but fascinating. All right, next up are the very low-density lipoproteins, or VLDLs. Where do they fit into this intricate transport system? Are they also from diet?
No, VLDLs are different. They are produced primarily in the liver, so they handle endogenous lipids, fats made by the body or stored there, not directly from the meal you just ate.
Okay, liver-made. What triggers their production?
Their production gets ramped up when there's an increased flow of free fatty acids coming to the liver, maybe from fat stores, or when the liver itself increases its own synthesis of fatty acids, for example, from excess carbohydrates.
Right.
The liver continuously makes certain apoproteins needed for VLDL, including ApoB100 that's different from the ApoB48 in chylomicrons, plus ApoE and the C apoproteins. These get incorporated into the VLDLs.
Is there a key assembly protein, like for chylomicron?
Yes, a critical protein here is the microsomal triglyceride transfer protein, or ATP. Its job is to load triglycerides onto the newly synthesized ApoB100 to form the nascent VLDL particle.
MTP.
And MTP is so crucial, in fact, that rare mutations that stop it from working cause a severe genetic disorder called apolipoproteinemia. People with this condition can't make VLDL or chylomicrons properly.
Wow. So what happens to these VLDLs once they're out in the plasma? Do they have a similar journey to chylomicrons?
They do, in part. Plasma VLDL gets broken down by the same LPL enzyme in the capillary beds, just like chylomicrons. LPL strips off triglycerides.
Okay.
As this triglyceride breakdown nears completion, what's left are VLDL remnants, which we usually call intermediate density lipoproteins, or IDLs.
IDL, so intermediate between VLDL and...
Exactly. Intermediate between VLDL and LDL. These IDLs have very short lifespan in the blood, less than 30 minutes, and they have two potential fates.
Okay, what are they?
About 40% to 60% of them are cleared directly from the plasma by the liver, again using those LDL receptors and the LRP receptor, recognizing ApoB100 and ApoE.
And the rest.
The remainder of the IDLs are then converted into LDLs. This happens through further removal of triglycerides by both LPL and that hepatic lipase, HL. During this conversion, other apoproteins like the C apoproteins and ApoE get transferred off, often moving to HDL.
So the IDLs are the precursors to the most infamous lipoprotein of all, low-density lipoproteins, or LDL, the one everyone worries about, the bad cholesterol.
Precisely. Virtually all LDL particles circulating in your blood are derived from VLDL via IDL. LDLs are very cholesterol-rich particles.
And they hang around for a while.
They do. They have a relatively longer half-life, about 1.5 to 2 days. And in people with normal triglyceride levels, a full 2/3 of the cholesterol in their plasma is found within LDL.
So how does the body get rid of LDL?
The primary way LDL is cleared from the plasma is through those LDL receptors, mainly on the liver. The receptor recognizes and binds to the ApoB100 protein on the LDL particle. There's also a smaller component of clearance that happens through non-receptor mechanisms, but the LDL receptor pathway is dominant.
And this is where familial hypercholesterolemia, or FH, comes in again, right? Because that's typically about defective LDL receptors.
That's exactly right. The most common cause of inherited high cholesterol, specifically autosomal dominant hypercholesterolemia, involves loss-of-function mutations in the gene that makes the LDL receptor, the LDLR gene.
So the receptors don't work properly or aren't there.
Correct. When these LDL receptors are defective or absent, the body can't clear LDL effectively, leading to very high levels of plasma LDL-C. This is the hallmark of FH.
And there's a very severe form, HoFH.
Yes, homozygous FH, HoFH, where someone inherits faulty genes from both parents. It's much rarer but very severe, associated with extremely high cholesterol from birth, accelerated ASCVD, and tragically, often premature death before the age of 30 if not treated aggressively.
How is that treated?
Treatment focuses on, well, inhibiting cholesterol synthesis with statins, which we'll talk more about, or more recently, by inhibiting another protein called angiopoietin-like protein 3, ANGPTL3, with monoclonal antibodies.
Okay. Now, what makes LDL bad? How does it actually cause problems like atherosclerosis?
That's a key point. LDL itself isn't inherently bad. It's needed to transport cholesterol. It becomes atherogenic, meaning it promotes plaque formation when it gets modified, often by oxidation, within the artery wall.
Oxidized LDL.
Right. This modification is a required step for the modified LDL to be taken up by specific scavenger receptors on immune cells called macrophages.
Macrophages, the cleanup crew of the immune system.
Kind of, but here they cause problems. When macrophages gobble up lots of this modified LDL, they become bloated with fat and transform into foam cells. These foam cells are a key component, a hallmark, of those early fatty streaks and plaques in arteries.
So the liver is really the key player in controlling LDL-C levels then, given its large number of LDL receptors.
Absolutely critical. The liver expresses a huge number of LDL receptors and is responsible for removing about 75% of all LDL from the plasma.
Wow, 3/4.
Yeah. Therefore, manipulating hepatic LDL receptor gene expression, getting the liver to make more receptors, is in fact the most effective way to modulate plasma LDL-C levels.
And that ties into treatments.
Directly. This is how some of our most effective dietary changes work, like cutting down on saturated fat and cholesterol. And it's also the primary mechanism behind our most powerful pharmacological treatments, like statins. They both work, in large part, by enhancing the liver's ability to produce and display more LDL receptors.
Fascinating how it all comes back to the liver's control system. Now let's talk about the good guys, or at least the ones with the better reputation. High-density lipoproteins, or HDL, these are the protective ones, right?
Yes, HDLs are generally considered protective lipoproteins because higher levels are associated with a decreased risk of coronary heart disease, or CHD. So generally speaking, higher levels of HDL are desirable.
And why are they protective? What do they do?
Their main protective effect is largely attributed to HDL's role in reverse cholesterol transport. This is a really crucial process.
Reverse transport, taking cholesterol back.
Exactly. HDL acts like a scavenger, or maybe a cleanup crew. It acquires excess cholesterol from cells out in the periphery, like those macrophages in the artery walls, and transports it back to the liver.
Okay.
Once back in the liver, that cholesterol can be processed and excreted from the body, often in the bile. This whole pathway is shown nicely in Figure 37.2 in our source material.
So HDL acts like a cleanup crew, collecting excess cholesterol and taking it back to the liver for disposal. Does it do anything else beneficial?
It seems to, yes. Beyond reverse cholesterol transport, HDL is thought to have several other potentially beneficial effects. These include anti-inflammatory actions, antioxidative properties protecting against damaging oxidation, and even helping prevent blood clots through antiplatelet and anticoagulant activities.
Wow, quite multifaceted.
It is. And when we talk about HDL, it's critical to highlight a specific protein, ApoAI. This is the major apoprotein found on HDL particles.
ApoAI.
And interestingly, its plasma concentration, the amount of ApoAI itself, is actually a more powerful inverse predictor of heart disease risk than the overall HDL cholesterol level itself.
So measuring ApoAI might be even more informative than just measuring HDL-C.
Potentially, yes.
Yeah.
Higher ApoAI is often linked to lower risk, and making ApoAI is absolutely required for the normal production of HDL. Mutations in the ApoAI gene that cause HDL deficiency are often associated with accelerated plaque formation.
And there are different types of HDL.
There are. We generally talk about two major subclasses of mature HDL particles in the plasma, and they're differentiated mainly by their content of ApoAI and another protein, ApoAI. There's some epidemiological evidence in humans suggesting that ApoACI might also be atheroprotective.
Let's go deeper into that reverse cholesterol transport mechanism. How does HDL actually acquire the cholesterol from those cells?
Okay, it starts with a specific transporter protein on the cell surface called ABCA1. This transporter facilitates the transfer of free, unesterified cholesterol out of the cell and onto a nascent, or newly formed, HDL particle, often called pre-1-HDL.
ABCA1 passes the cholesterol out. Then what?
Once this nascent HDL grabs the free cholesterol, an enzyme circulating in the plasma called ELSKI, that stands for lecithin, cholesterol acetyltransferase, gets to work.
LC.
ELSKI esterifies that newly acquired free cholesterol, basically attaching a fatty acid to it. This newly esterified cholesterol is nonpolar, so it moves into the hydrophobic core of the HDL particle.
Making the particle bigger.
Exactly. As HDL continues to pick up and esterify more cholesterol, it becomes progressively more spherical, larger, and less dense. This larger, more mature particle is often called HDL2.
Okay, so it fills up with cholesterol esters. What happens to them then?
As the cholesterol ester content of this HDL2 particle increases, these cholesterol esters begin to be exchanged for triglycerides from other lipoproteins circulating nearby, like halomicrons, VLDLs, the remnants, and even LDLs.
An exchange program.
Precisely. This exchange is mediated by another key protein called cholesterol ester transfer protein, or CETP.
CETP, okay.
And remarkably, in humans, the CETP-mediated exchange accounts for the removal of about 2/3 of the cholesterol associated with HDL. The cholesterol esters transferred off HDL onto other lipoproteins are then subsequently metabolized as part of those recipient lipoproteins.
So CETP seems to play a huge role in moving cholesterol off HDL. But I've heard that targeting CETP with drugs hasn't been as straightforward as one might hope. That sounds like one of those surprising facts about how complex the body really is.
That's an extremely important and, yes indeed, a surprising and somewhat sobering point in drug development. Drugs targeting CETP were designed with a seemingly logical goal: raise HDL-C levels, the good cholesterol, and maybe lower LDL-C too. A win-win, right?
Sounds ideal on paper.
Exactly. However, large clinical trials with several CETP inhibitors while effectively achieving these changes in lipid numbers, paradoxically showed an increase in adverse cardiovascular events, things like angina, need for revascularization procedures, heart attacks, heart failure, and even death in some cases.
Wow, the opposite of what was intended.
Precisely. This was a crucial counterintuitive finding. It completely reshaped our thinking, reminding us that simply manipulating a single number, like HDLC, doesn't always translate to better patient outcomes. The body's lipid system is incredibly complex and interconnected.
That's a stark reminder, absolutely. So interventions can have unexpected consequences. What happens to the HDL2 particle after the CETP exchange when it's taken on triglycerides?
The triglyceride that gets transferred into the HDL2 particle is then broken down, primarily in the liver, by that enzyme we mentioned earlier, hepatic lipase, or HL.
HL again.
Yes. This hydrolysis of triglycerides by HL regenerates smaller, denser, spherical HDL3 particles. These HDL3 particles can then recirculate and pick up more free cholesterol from tissues, continuing the reverse cholesterol transport cycle.
So HL recycles the HDL. Is HL affected by anything?
It is. HL activity is sensitive to hormone regulation. For instance, androgens, male hormones, tend to increase HL activity, which partly explains why men generally have lower HDL-C levels than women. Estrogens tend to reduce HL activity, but the effect isn't as strong. HL appears to have a pivotal role in regulating overall HDL-C levels, as increased HL activity is commonly seen in many patients who have low HDL-C.
Okay, that covers HDL. And finally, just a brief mention of lipoprotein, or LPA. It seems to be in a category of its own, but also quite atherogenic.
It is somewhat unique. LPA is essentially an LDL particle that has an additional large protein called ApoA attached to it, and ApoA is structurally very similar to plasminogen, a protein involved in breaking down blood clots. LPA appears to possess significant atherogenic properties, meaning it contributes to plaque formation, and it's considered an independent risk factor for cardiovascular disease, separate from LDL-C itself.
Right, another factor to consider in the risk profile. Okay, with all this incredibly detailed understanding of lipoproteins, it's clear that the ultimate goal of therapy for dyslipidemias isn't just about tweaking numbers on a lab report. It's about something far more profound. Reducing the risk of these major cardiovascular events, heart attacks, strokes, both fatal and non-fatal.
Precisely. That's the end game. And to achieve that, a comprehensive ASCVD risk assessment is paramount. You have to know who is at risk and how high that risk is.
So what goes into that assessment? What are the key factors?
We look at the major conventional risk factors. These are well established and include things like elevated LDL-C, obviously, but also reduced HDL-C, cigarette smoking, hypertension, high blood pressure, defined typically as 390 mmHg or higher, or being on medication for it, and type 2 diabetes mellitus. Diabetes itself is considered a high or very high risk condition. Then there's advanced age, generally men over 45, women over 55, and having a family history of premature heart disease and a close relative, like a parent or sibling, specifically a male relative under 55 or female under 65.
And race is sometimes included now, too.
Yes, that's relatively newer. As more data has become available, ASCVD risk calculators have begun to incorporate race into their assessments, trying to make them as accurate as possible for diverse populations. There's a helpful flowchart in our source, figure 37-3, that visually lays out this risk assessment and management process.
That brings us to a really fascinating frontier in risk assessment, the power of genetic information. I understand genetic testing for specific mutations is becoming increasingly important for certain conditions like FH.
It's a significant advancement, absolutely. Genetic testing for those single gene mutations that cause familial hypercholesterolemia mutations in genes like LDLR, APOB, PCSK9, and LDLR-AP1 is now recommended for patients who are suspected of having FH, and importantly, also for their at-risk relatives.
And the benefit is identifying it early.
Exactly. The benefit of this early identification is immense. If we can pinpoint individuals and their family members at risk for FH before the high cholesterol phenotype even fully manifests clinically, it provides crucial opportunities. We can intervene earlier to reduce LDL-C, potentially before significant coronary artery disease even starts to develop.
So it changes their lifetime exposure.
Precisely. Children identified with FH who begin treatment early have a lower cumulative exposure to high LDL-C over their lifetime, and, consequently, a demonstrably reduced risk of ASCVD compared to their affected parents who maybe weren't identified or treated until later. It's a powerful argument for early intervention.
So early testing could really change the trajectory of someone's health, preventing disease rather than just managing it later. And I've heard about cascade testing in this context. What's that?
Yes, cascade testing. It's the process of systematically screening at-risk family members once a genetic mutation causing FH is found in one individual, the index case.
Testing the whole family tree, essentially.
Kind of, yeah, the immediate branches at least. It's considered a highly cost-effective way to identify many more patients with FH and prevent the associated illness and premature death. Interestingly, despite its proven effectiveness, cascade testing is not routinely or universally done in the U.S. at present, which is definitely a point of ongoing discussion and focus in the medical community.
Seems like a missed opportunity, potentially.
It does. And looking beyond these single-gene causes, there's also significant interest now in developing polygenic risk scores.
Polygenic, meaning many genes.
Exactly. Based on large-scale genetic studies, these scores aim to assess the combined aggregate contributions of many small genetic variations that together can increase LDL-C levels and consequently atherosclerotic cardiovascular risk. This really hints at the future of personalized medicine, where we might use an individual's unique genetic blueprint to much better predict and prevent disease down the line.
Speaking of prevention, it's important to distinguish between primary and secondary prevention. Can you clarify the key difference?
Absolutely. Primary prevention involves managing risk factors to prevent a first-ever ASCVD event. It's about stopping the disease before it starts in someone who hasn't had a heart attack or stroke yet.
Okay. And secondary?
Secondary prevention, on the other hand, is aimed at patients who have already had a prior ASCVD event, like a heart attack, a stroke, or maybe a bypass surgery or stent. For these individuals, risk factors must be reduced much more aggressively to prevent further events. The risk is already known to be very high.
And it's not just about medication, right? You mentioned non-pharmacological approaches. A holistic approach seems crucial.
It is absolutely essential. A comprehensive approach to ASCVD risk reduction goes well beyond just cholesterol management. It must include critical lifestyle interventions.
Like
things like smoking cessation, hugely important weight management, regular physical activity, adopting healthy eating habits, appropriate use of aspirin in certain individuals, and diligent management of blood sugar, if diabetic, and blood pressure. It's crucial that all treatment plans aiming to reduce ASCVD risk include patient counseling centered around these lifestyle changes.
you have to address the whole picture.
The whole picture. Furthermore, before starting drug therapy, clinicians must also consider and rule out secondary causes of dyslipidemias. These can include certain other medications a patient might be taking or other underlying health conditions. There's a table in the source, table 37.5, detailing these. And patients should also be evaluated for metabolic syndrome.
Metabolic syndrome, right? That's quite common.
Very common, affecting more than 1 in 3 adults. It's a cluster of conditions, things like insulin resistance, central obesity, high blood pressure, low HDL-C levels, maybe a proclotting state, and vascular inflammation. Having metabolic syndrome substantially increases the risk of cardiovascular disease.
So how do clinicians actually put all this risk information together in practice? What tools do they use to assess risk and guide therapeutic choices, especially for starting medications like statins?
A key tool used widely, particularly in the U.S., is the pooled cohort equation, or PCE. This equation came out of the 2014 ACCHA guidelines and is still referenced in the 2018 guidelines.
Pooled cohort equation, what does it do?
It was developed using data from large, diverse patient populations, and it estimates an individual patient's 10-year risk of having a first ASCVD event specifically, a non-fatal heart attack, death from coronary heart disease, or a fatal or non-fatal stroke.
And what information does it use?
It calculates this risk based on several key parameters: age, gender, total cholesterol, HDL-C level, race, systolic blood pressure, smoking status, and whether the patient has a history of diabetes or is being treated for hypertension.
Okay, quite comprehensive.
It is. It's specifically intended for assessing risk for primary prevention in patients between the ages of 20 and 79 years. And importantly, the ASCVD risk estimator based on the PCE is readily available online and as a mobile app, making it a very practical tool for clinicians right there in the office.
And these risk scores then directly guide the recommendations for statin use?
Pretty much, yes. While understanding optimal lipoprotein levels is helpful context, the 2018 AACC cholesterol guidelines specifically recommends initiating and titrating statin therapy to achieve particular LDL-C % decrease goals in certain patient groups. The specific goal depends on their baseline risk category and age.
And statins are really the go-to.
They are. Because the overwhelming body of evidence for ASCVD risk reduction from lipid-lowering therapies comes from large, well-conducted statin trials. Evidence-based statin therapy of the appropriate intensity is considered the absolute hallmark of drug therapy for dyslipidemias. They're truly the first line for most patients needing medication.
So who are the key candidates for statin therapy, perhaps even regardless of their calculated risk score?
Right. Patients aged 40 to 75 years who have a known history of clinical ASCVD, meaning they've already had an event, or those who have diabetes, should generally be offered statins. Also, individuals with very high LDL-C levels, meaning 190 mg/dL or greater, are typically started on statins regardless of their calculated 10-year risk score.
Okay. And for others in that age range without those conditions?
For primary prevention in patients aged 40 through 79 years who don't have diabetes and whose LDL-C is between 70 and 189 mg/dL, the use of the PCE risk score is recommended to identify those individuals who are more likely to benefit from starting statin treatment based on their 10-year risk estimate.
And the intensity matters. Low, moderate, high.
Yes, the intensity is key. Statin therapy is classified by intensity low, moderate, or high based on the average LDL-C lowering expected from specific doses of different statins. This typically ranges from about a 30% reduction for moderate intensity up to 50% or more for high intensity. Table 37 and 7 in our source details which statins and doses fall into which intensity category.
This brings us squarely to statins, which you've rightly called the cornerstone of drug therapy for dyslipidemias. They really have revolutionized treatment. So let's get into how they actually work. What's their core mechanism of action?
Okay. Statins exert their major effect, that reduction of LDL-C levels, by basically mimicking a molecule that's naturally found in the cholesterol synthesis pathway called mevalonic acid.
They mimic it.
Yes, they competitively inhibit a key enzyme called HMG-CoA reductase. This enzyme catalyzes a critical, rate-limiting step in your body's cholesterol production line, mainly in the liver. Think of it as a major bottleneck in the pathway.
So they block the bottleneck.
Exactly. By slowing down this crucial step, the conversion of HMG-CoA to mevalonate statins effectively inhibit the liver's ability to synthesize its own cholesterol.
So less cholesterol being made in the liver. What's the downstream effect of that? How does that lower cholesterol in the blood?
Well, when the liver's own cholesterol production is inhibited, it triggers a really clever compensatory mechanism. The liver cells respond by increasing the expression of the LDL receptor gene. They basically decide, okay, if we can't make enough cholesterol, we need to pull more in from the outside.
So they put out more receptors to grab LDL from the blood.
Precisely. More LDL receptors displayed on the surface of the liver cells means the liver becomes much more efficient at removing LDL-C particles from the bloodstream. And that's the primary way statins lower circulating LDL-C levels.
Makes sense. Do they work in other ways too?
They do have some secondary effects. Statins can also help reduce LDL-C levels by enhancing the removal of LDL precursors, specifically those VLDL and IDL particles we talked about. And they can also decrease the liver's production of VLDL in the first place. This reduction in VLDL production is thought to be partly mediated by the reduced cholesterol synthesis, since cholesterol is a required building block for VLDLs.
And they affect triglycerides too.
Yes, particularly the more potent statins at higher doses, drugs like atorvastatin, simvastatin, rosuvastatin. They can also significantly reduce triglyceride levels, especially when those high triglycerides are mainly due to elevated VLDL levels. There's a figure in the source, figure 37-4, that illustrates this whole HMG-CoA reductase inhibition and the downstream effects quite well.
Excellent. Less production, more efficient removal via receptors. Now let's talk about their pharmacokinetics, how these drugs behave in the body. Absorption, distribution, metabolism, excretion, the whole ADME picture.
Right. After you take a statin pill, its absorption from the intestine can be quite variable, typically ranging somewhere between 30% and 85%.
That's a wide range.
It is. Most statins are actually administered in their active form, ready to work. But a couple, specifically simvastatin and lovastatin, are given as inactive lactones, and they need to be transformed by the liver into their active hydroxy acid form first.
Okay. And what happens after absorption?
A key feature of nearly all statins is that they undergo extensive first-pass uptake by the liver. This means a significant portion of the drug absorbed from the gut goes directly into the liver cells before it even reaches the general circulation.
So the liver gets the first crack at it.
Exactly. This process is primarily handled by a special transporter protein on liver cells called OATP1B1. This extensive first-pass effect is why only a relatively small amount of the active drug actually makes it into your systemic bloodstream, typically only about 5% to 30% of the administered dose. The liver concentrates the drug where it's needed most.
I've heard that timing matters for taking statins. Is that true? When should people take them?
It does matter for some of them, yes. Your liver's cholesterol synthesis naturally peaks during the night, roughly between midnight and 2:00 a.m.
Okay.
Therefore, statins that have shorter half-lives, meaning they don't stay active in the body for very long, typically 4 hours or less, should ideally be taken in the evening. This aligns their peak effect with the time of peak cholesterol production. This includes most statins except for atorvastatin and rosuvastatin.
And those two are different.
Yes, atorvastatin and rosuvastatin have significantly longer half-lives, around 20 hours or so. This means they provide a more sustained effect throughout the day and night, which offers more flexibility in their dosing time. They can often be taken any time of day, which can definitely help with patient adherence.
That's practical. And how are they metabolized and ultimately eliminated from the body?
Their metabolism largely involves certain liver enzymes, primarily from the cytochrome P450 system, or CYP enzymes.
The CYP system, right.
Yeah. For example, atorvastatin, lovastatin, and simvastatin are mainly processed by CYP3A4 and CYP3A5 enzymes. Fluvastatin is mostly handled by a different one, CYP2C9, with some help from others. Rosuvastatin is a bit unique in that it's primarily excreted unchanged. It doesn't get extensively broken down by these CYP enzymes.
And pravastatin.
Pravastatin also stands out. It's not extensively metabolized by the CYP system at all, and is largely excreted unchanged, mostly in the urine. It's also notable that the breakdown products, the metabolites of most statins, actually still retain some HMG-CoA reductase inhibitory activity, so they continue to contribute to the effect.
Do they bind to proteins in the blood?
Yes, highly. In the plasma, over 95% of most statins and their active metabolites are bound to proteins, mainly albumin. Pravastatin is the exception, again, being only about 50% bound. Peak plasma concentrations are usually reached within 1 to 4 hours after taking the pill.
In elimination, where do they end up?
Ultimately, the liver processes all statins, and the majority, more than 70% of the statin metabolites, are excreted by the liver into the bile, and then eliminated in the feces. A smaller amount might be eliminated via the kidneys.
Okay, so that covers how they move through the body. What kind of therapeutic effects can patients expect? How much do they typically lower LDL-C, for example?
The effect of statins on LDL-C levels follows a pretty predictable pattern, often described as a log-linear dose-response relationship. What that means practically is that LDL-C is reduced by approximately 6% from baseline, with each doubling of the statin dose.
Only 6% per doubling?
Roughly, yes. So the biggest bang for your buck comes from the initial dose, and subsequent dose increases yield smaller incremental benefits, though still significant. The maximal effects on plasma cholesterol levels are generally achieved within about 7 to 10 days of starting therapy or changing a dose.
And they work for most people with high LDL.
Yes, statins are remarkably effective in almost all patients with high LDL-C levels. The significant exception, as we touched on earlier, is patients with homozygous familial hypercholesterolemia, HoFH.
Right, because the receptors are faulty.
Exactly. They show very attenuated or reduced responses to statins because both copies of their LDL receptor gene are dysfunctional. Their liver simply can't make enough functional receptors for the statin to work effectively via that mechanism.
What about triglycerides? Do statins help with those too?
Yes, absolutely. For patients who have triglyceride levels greater than, say, 250 mg/dL, statins can substantially reduce these levels. The percentage reduction achieved for triglycerides is typically similar to the percentage reduction observed for LDL-C with that same statin and dose.
And HDL-C, the good cholesterol, does that go up?
In most studies of patients treated with statins, a modest increase in HDL-C, usually in the range of 5% to 10%, has been observed. This increase seems to happen regardless of the specific statin used or the dose, at least in patients who start with elevated LDL-C and sort of gender-appropriate HDL-C levels.
But what about people starting with low HDL?
That's less clear. In patients who have significantly reduced HDL-C levels to begin with, say, less than 35 milligel statins might differ in their effects, and honestly, more studies are needed to really figure out if the effects of statins on HDL-C in this specific low HDL patient population are clinically meaningful in the long run.
Okay. Moving on to the crucial topic of adverse effects and drug interactions, which are always important considerations for any medication. What's the major adverse effect associated with statins that people hear about most?
The major adverse effect associated with statin use, and the one patients are often most concerned about, is myopathy.
Myopathy, muscle problems.
Exactly. This term covers a broad spectrum of muscle complaints. It can range from mild muscle soreness or weakness, which we call myalgia, all the way up to the potentially life-threatening condition of rhabdomyolysis, where muscle tissue breaks down rapidly.
What increases the risk of these muscle issues?
The risk definitely increases with higher statin doses and consequently higher plasma concentrations of the statin. So any factor that slows down how your body breaks down or eliminates statins is associated with an increased risk of myopathy.
Like what factors?
These include things like advanced age, especially being over 80 years old,
Right.
having underlying liver or kidney dysfunction, being in a perioperative period like around surgery, having a small body size, or having untreated hypothyroidism.
Should people get routine blood tests to check for muscle damage?
Generally, no. Routine measurements of creatinine kinase, or CK, which is a marker for muscle damage, are not considered necessary unless the patient is actually experiencing muscle symptoms, or if they're also taking another drug that's known to significantly enhance the risk of myopathy when combined with a statin.
Okay. What are some of those common drug interactions that increase myopathy risk?
Concomitant use of drugs that either slow down how statins are metabolized, mainly by those CYP enzymes, or interfere with their uptake into the liver via that OATP1B1 transporter is strongly associated with an increased risk of myopathy and rhabdomyolysis.
Which drugs are common culprits?
The most common statin interactions that increase myopathy risk occur with drugs like fibrates, especially gemfibrozil, that's a big one, and with cyclosporine, an immunosuppressant. Also, certain macrolide antibiotics like erythromycin and ozol antifungals like itraconazole.
Any others?
Yes. Other drugs that can increase the risk include niacin, although it's rarer, certain HIV protease inhibitors, the heart rhythm drug amiodarone, and the antidepressant nefazodone. These interactions can lead to significantly higher, potentially toxic levels of the statin in your body.
And what about liver toxicity, hepatotoxicity? Is that a significant concern with statins?
Serious hepatotoxicity is thankfully very rare. It's also unpredictable. The estimated rate is only about 1 case per million person-years of use.
That's very low.
Extremely low. And because it's so rare and unpredictable and routine monitoring wasn't proving effective, it's important information that since 2012, the FDA no longer recommends routine periodic monitoring of liver enzymes like ALT after starting statin therapy.
So no routine liver tests just for being on a statin?
Correct. The recommendation now is that liver enzymes should only be evaluated if a patient presents with clinical symptoms that suggest liver injury, things like unusual fatigue, loss of appetite, abdominal pain, dark urine, or jaundice after starting or changing their statin treatment. However, it's absolutely critical to remember that statin use is contraindicated in patients who have active liver disease.
Are there any other special precautions or contraindications listeners should be aware of?
Yes, a couple important ones. Statins should be used with caution in patients who have kidney impairment. Atorvastatin is often the preferred statin for patients with severe kidney dysfunction because it doesn't require dose adjustment based on kidney function, unlike some others.
Yeah, in pregnancy.
Crucially, statins are contraindicated during pregnancy. They should ideally be discontinued prior to conception if possible. The data regarding statin use while breastfeeding is limited, so its use during lactation is generally discouraged as well.
Let's delve into those drug interactions a bit more, especially with gemfibrozil. You mentioned it was strongly associated with myopathy. Why is that interaction so problematic?
Right, gemfibrozil is the drug most commonly associated with statin-induced myopathy. It acts in two main ways to increase statin levels. First, it inhibits the uptake of the active forms of statins into the liver cells via that OATP1B1 transporter we talked about.
Blocks the entry.
Yes. And second, it also interferes with the way most statins are processed and inactivated in the liver through a process called glucuronidation. This combination can nearly double the plasma concentration of the active statin, significantly increasing the risk of muscle problems.
And what about niacin? You mentioned that interaction too.
When statins are given with niacin, the resulting myopathy is thought to be caused by a different mechanism, likely a pharmacodynamic interaction, where the combination leads to an enhanced inhibition of cholesterol synthesis within the skeletal muscle itself.
And this ties back to the FDA's surprising decision in 2016.
It does. It's worth highlighting again that surprising fact. In 2016, the FDA actually withdrew approval for combination pills containing statins with either fibrates or niacin. This was a big deal. Despite these combinations lowering lipid numbers on paper, large studies showed no additional reduction in actual ASCVD events, heart attacks, strokes, compared to statin therapy alone.
So the numbers looked better, but the outcomes didn't improve.
Exactly, a crucial lesson in focusing on patient outcomes over just lab values.
What about interactions with other common medications, like antibiotics or antifungals, that use that CYP3A4 pathway?
Right. Drugs that strongly inhibit the CYP3A4 enzyme system can significantly interfere with the breakdown of statins that rely on that pathway, specifically atorvastatin, lovastatin, and simvastatin. Common examples include certain macrolide antibiotics like erythromycin and clarithromycin, azole antifungals such as itraconazole and ketoconazole, the immunosuppressant cyclosporin, certain HIV protease inhibitors, and amiodarone.
So these can raise statin levels.
Yes. These pharmacokinetic interactions lead to increased plasma concentrations of these specific statins and their active metabolites, raising the myopathy risk. Because pravastatin, fluvastatin, and rosuvastatin are not extensively metabolized by CYP3A4, these particular statins might be less likely to cause myopathy when used concurrently with one of these CYP3A4 inhibiting drugs. However, clinicians must always carefully weigh the benefits of any combined therapy against the potential risk of myopathy.
And there were specific warnings about simvastatin.
Yes, following reviews, the FDA issued specific warnings back in 2012 regarding simvastatin due to its higher risk of myopathy, especially at the highest dose, 80 milligram, which is now rarely used. The warnings explicitly stated that simvastatin should not be used in combination with strong CYP3A4 inhibitors like itraconazole, ketoconazole, erythromycin, clarithromycin, HIV protease inhibitors, nifamazidone, or gemfibrozil, or cyclosporine. Specific dose limitations also apply when simvastatin is combined with other drugs like amlodipine, amiodarone, diltiazem, or verapamil. For instance, the dose shouldn't exceed 20 mg daily with amlodipine or amiodarone and no more than 10 mg daily with diltiazem or verapamil.
Lots of specifics to keep track of there. Beyond these interactions, what are some general clinical considerations when choosing which statin to use for a patient?
That's right. It's not just about picking any statin. The choice should always be patient-specific. You need to consider factors such as cost. There are generic options now, which helps potential drug interactions based on the patient's other medications, their history of possible adverse effects, and of course, the desired intensity of LDL-C lowering needed based on their risk.
High, moderate, or low intensity.
Exactly, referring back to that classification in Table 37.7.
And for patients who might struggle with the myalgia, those common muscle aches that aren't severe myopathy but still bothersome, are some statins better tolerated?
There's some evidence suggesting that rosuvastatin and pravastatin may be better tolerated than other statins and could be considered for patients who have a history of muscle aches with previous statins.
Yeah.
It's not guaranteed, but worth trying. Also a practical point for lovastatin. Its absorption is significantly increased when taken with food, so patients should be specifically instructed to take it with their evening meal.
What about other concerns people sometimes raise, like effects on cognition or diabetes risk?
Okay, good questions. Concerns have been raised about possible cognitive impairment memory issues, fogginess with statins. However, a thorough review of the published data by regulatory agencies like the FDA does not suggest that statins harm cognition. In fact, some observational studies even suggest that statins might have a role in the prevention of dementias, although that's not definitively proven.
Okay, so the evidence doesn't really support cognitive harm. What about diabetes?
There is evidence that statins, especially at higher doses, likely confer a small increased risk of developing new-onset type 2 diabetes.
That sounds concerning.
It does, but it's crucial to put it in perspective. Numerous analyses have consistently shown that the significant beneficial effects of statins on reducing major ASCVD events, preventing heart attacks and strokes, and improving mortality far outweigh this small increased risk of developing diabetes. For most people at risk for ASCVD, the benefit strongly favors statin use.
That's important context. And finally, can children take statins?
Yes, some statins have been studied and approved for use in children, specifically those with heterozygous familial hypercholesterolemia, HeFH. Atorvastatin, lovastatin, and simvastatin are indicated for children aged 11 years and older, while pravastatin is approved for children 8 years and older. This allows for earlier treatment in these high-risk kids.
Okay, so statins are the cornerstone, incredibly effective, but with nuances regarding interactions and side effects. But what about when statins aren't enough, or if a patient truly can't tolerate them? What's the general landscape of non-statin therapies look like?
Right. While statins remain absolutely central, the 2018 ACK Cholesterol Management Guideline does recommend considering the use of ezetimibe and/or those PCSK9 inhibitors we mentioned briefly as add-on therapies for cholesterol management, particularly in very high-risk patients, like those with established cardiovascular disease who aren't at their LDL goal on maximally tolerated statins.
So add-ons are part of the picture. Have these non-statins been studied rigorously?
Yes. Several important large clinical trials have specifically evaluated whether various non-statin agents, including fibrates, niacin, ezetimibe, PCSK9 inhibitors, and specific fish oil preparations like icosapentaethol result in further reductions in ASCVD risk when used in addition to statins.
And what did those trials show? We already touched on niacin and fibrates.
Exactly. And as we discussed, there was that significant and perhaps surprising development in 2016. Based on major trials like AIM-HIGH for niacin and ACCORD for fenofibrate, the FDA actually withdrew its approval indications for using niacin extended release or fenofibrate in addition to statins, specifically for the purpose of further ASCVD risk reduction.
Because they didn't show that additional benefit.
Precisely. Despite improving lipid numbers, they showed no additional reduction in actual cardiovascular events compared to just taking the statin alone. This really solidified the primary role of statins and underscored that just improving lab numbers isn't always enough. You need to demonstrate real patient benefit and outcomes.
So how should clinicians approach using non-statins now?
Well, there was an expert consensus update from the ACC in 2017, specifically on the role of non-statin therapies to help guide clinicians. Ultimately, the use of non-statins in high-risk patient populations requires careful, shared decision-making between patients and their physicians, really weighing the potential benefits, the remaining risks, the costs, and the strength of the evidence for each specific situation.
What about patients with very high triglycerides? That's a slightly different situation, potentially linked to pancreatitis risk, right?
Absolutely. Extremely elevated triglycerides, especially when levels exceed, say, 1,000 mg/L, are an important risk factor for acute pancreatitis, which can be very serious.
So what's recommended there?
In these cases, treatment with agents that are most effective at specifically reducing triglyceride levels, primarily fibrates or prescription-strength fish oil products, is recommended specifically to reduce that pancreatitis risk. These triglyceride-lowering therapies might be used in addition to statin treatment if the patient also has ASCVD risk factors that make them a candidate for statin therapy anyway.
Okay, let's dive into some specific non-statins. Starting with ezetimibe, the cholesterol absorption inhibitor. How does it work differently from statins again?
Right, ezetimibe is quite unique. It was the first compound approved that lowers cholesterol by directly inhibiting cholesterol absorption from the food you eat, right there in the enterocytes, the cells lining your small intestine.
So it blocks uptake from diet.
Exactly. This is a direct contrast to statins, which, as we know, primarily work by inhibiting cholesterol synthesis in the liver. Ezetimibe achieves its effect by specifically blocking that transport protein we mentioned earlier, Niemann-Pick C1-like 1, or NPC1L1.
And how effective is it?
In human studies, ezetimibe has been shown to reduce dietary and biliary cholesterol absorption by about 54%. Now, when you block absorption like that, your body often tries to compensate by ramping up its own cholesterol synthesis in the liver.
Ah, the body fights back.
It does. But this compensatory increase can be effectively counteracted when ezetimibe is given with a statin or potentially with one of those newer ACL inhibitors that also block synthesis.
So it's very complementary to statins then. It hits cholesterol from a different angle.
Exactly. They work very well together. By reducing the amount of cholesterol delivered to the liver from the gut via those chylomicron remnants, ezetimibe might potentially reduce plaque formation directly, but it also has an indirect effect. The reduced cholesterol delivery to the liver prompts the liver to make more LDL receptors.
Just like statins do, but via a different trigger.
Precisely. More LDL receptors enhance the clearance of LDL-C from the bloodstream. On its own, ezetimibe typically lowers LDL-C levels by about 15% to 20%. So its role as monotherapy for just high LDL-C is generally limited to that small group of patients who really cannot tolerate statins at all.
They're powerful in combination.
Yes, its actions are highly complementary to those of statins and ACL inhibitors. Dual therapy with ezetimibe and a statin leads to additive reductions in LDL-C levels. You get a significantly greater reduction than with the statin alone. For instance, the LDL-C reduction achieved with, say, the highest dose of simvastatin plus ezetimibe can be similar to, or sometimes even greater than, what you get with the highest intensity statins used alone.
How is ezetimibe handled by the body, and are there any specific preparations or crucial drug interactions to be aware of?
Ezetimibe is taken orally, usually as a 10-milligram tablet, and can be taken pretty much any time of day, with or without food, which is convenient. It undergoes something called enterohepatic recirculation. It gets absorbed, goes to the liver, excreted into bile, then reabsorbed from the intestine again, which helps prolong its action.
Okay, where is it eliminated?
About 70% is ultimately excreted in the feces and about 10% in the urine. Now, a crucial interaction. Bile acid sequestrants drugs like cholestyramine significantly inhibit the absorption of ezetimibe. So these two classes of agents should definitely not be taken at the same time.
Good to know. Any combination pills?
Yes, ezetimibe is available in fixed-dose combination tablets with either simvastatin or that newer drug, bempedoic acid.
And adverse effects. Generally well tolerated.
Generally, yes. Other than rare allergic reactions, ezetimibe is usually well tolerated.
Yeah.
However, very rare cases of severe muscle breakdown, rhabdomyolysis, have been reported, although a clear cause and effect is hard to establish. And it's important to remember, any combination products containing ezetimibe and a statin carry the contraindications of the statin component, particularly regarding pregnancy and nursing.
Okay. Next, let's explore the bile acid sequestrants, sometimes called resins. Cholestyramine, cholestyramine, and the newer one, cholecyvelum. You mentioned these are among the oldest cholesterol-lowering drugs, right? And perhaps the safest in some ways.
They are indeed among the oldest hypolipidemic drugs available, and yes, they are often considered probably the safest in a specific sense. Because they are not absorbed systemically from the intestine, they pretty much stay within the digestive tract.
So they don't get into the bloodstream.
Correct. And partly for this reason, they are sometimes recommended as an option for younger patients, say aged 11 to 20 years, where long-term systemic exposure might be more of a concern. While statins are definitely more effective, these resins can be utilized as a second-line option if statin therapy doesn't sufficiently lower LDL-C levels, or perhaps in cases of genuine statin intolerance where other options aren't suitable.
And their mechanism of action, how do they work if they're not absorbed? It involves bile acids, right?
Exactly. Bile acid sequestrants are large, highly positively charged polymers, or resins. They work by binding strongly to the negatively charged bile acids within the intestine.
Like magnets.
Sort of, yeah. Because the resins themselves are not absorbed, the bile acids that get bound to them are then trapped and excreted in the stool rather than being reabsorbed.
And normally bile acids get recycled.
Very efficiently. Normally, more than 95% of the bile acids secreted into the intestine are reabsorbed further down and returned to the liver. By interrupting this intrahepatic circulation, the resins deplete the body's total pool of bile acids.
So the liver has to make more.
Precisely. The liver responds by increasing its synthesis of new bile acids from cholesterol. This increased demand for cholesterol within the liver leads to a decline in the liver's cholesterol content, which, in turn, stimulates the production of more LDL receptors on the liver cell surface, an effect similar to what statins achieve, though through a different mechanism.
More LDL receptors again.
Yes. The increased number of hepatic LDL receptors enhances LDL clearance from the blood and lowers plasma LDL-C levels. However, there's a slight catch. This beneficial effect is partially offset because the increased bile acid synthesis pathway also tends to upregulate HMG-CoA reductase activity, boosting cholesterol synthesis a bit.
And does it affect triglycerides?
Yes, and this is an important point, especially for certain patients. The resin-induced increase in bile acid production is also accompanied by an increase in the liver's triglyceride synthesis. So for patients who already have significant hypertriglyceridemia, bile acid sequestrants can actually increase triglyceride levels further, which is undesirable.
Good to know. So what kind of LDL-C reduction can we typically expect from these resins, and what are the main side effects, likely GI-related?
The reduction in LDL-C by resins is dose-dependent. Typical doses might lead to a 12% to 18% reduction in LDL-C. Maximal doses could potentially reduce LDL-C by as much as 25%, but honestly, these higher doses often cause pretty intolerable gastrointestinal side effects, limiting their use.
So compliance can be an issue.
Definitely. The maximal LDL-C reduction for a given resin dose is usually seen within 1 to 2 weeks. In patients who start with normal triglyceride levels, their triglycerides might transiently increase when starting a resin, but often return to baseline levels later. When resins are used in combination with a statin, they're usually prescribed at submaximal doses precisely because of these tolerability issues.
And how are these preparations administered, given they're powders or tablets, but not really absorbed?
The older powdered forms, cholestyramine and cholestyramine, are typically mixed with a non-carbonated fluid like water or juice, and then swallowed. Patients usually start with a low dose, maybe once or twice a day, often before meals, and gradually increase the dosage as tolerated. Cholecyvelum, the newer one, is available both as a tablet and as powder packets, which can offer more flexible and perhaps more convenient dosing options.
Given that they're not absorbed systemically, I imagine the adverse effects are mostly localized to the GI tract, as you hinted.
That's generally correct. The resins are usually safe from a systemic point of view due to their lack of absorption. However, because they are often administered as chloride salts, rare instances of a specific type of metabolic imbalance called hyperchloremic acidosis have been reported, mainly in younger patients or those on high doses.
And the triglyceride issue is a contraindication.
Yes. It's crucial to remember that severe hypertriglyceridemia is a contraindication for using cholestyramine and cholesterol because these resins are known to increase triglyceride levels. There's less data on cholecystyrul's effect on triglycerides, but caution is still warranted.
What about the common GI side effects?
The most common complaints, especially with the older powdered forms, include a gritty or unpleasant texture, bloating, dyspepsia, indigestion, and constipation, which can sometimes be severe.
Any tips to manage those?
Yes, these symptoms can often be minimized by ensuring the drug is fully suspended or dissolved in the liquid before drinking, maintaining adequate water intake throughout the day, and sometimes using a stool softener or a fiber supplement like psyllium. Cholestyramine, the tablet form, may be less likely to cause dyspepsia, bloating, and constipation compared to the powders.
And given their binding properties in the gut, do they interfere with the absorption of other medications?
This is a critical practical point. Yes, cholestyramine and cholesterol, because they are non-specific binders, can bind and interfere with the absorption of many other drugs taken orally.
Like which ones?
Examples include thiazide diuretics, furosemide, propranolol, L-thyroxine, thyroid hormone, digoxin, warfarin, and even some statins themselves.
So timing is key.
Absolutely. Patients are usually advised to take their other medications either at least 1 hour before or 3 to 4 hours after taking a dose of these bile acid sequestrants to avoid this binding interaction in the gut. Interestingly, cholestyramine appears to interfere less with the absorption of fat-soluble vitamins or certain other drugs like digoxin, lovastatin, warfarin, metoprolol, etc., but it can reduce concentrations of some others like verapamil.
And safety in kids or pregnancy?
As mentioned, they are sometimes used in older children and adolescents, but the safety and efficacy of cholestyramine specifically haven't been studied extensively in pediatric patients or in pregnant women, so caution is advised there.
Now let's move on to niacin, also known as nicotinic acid. This one is interesting because it's actually a vitamin B3, but it has these surprising hypolipidemic powers at higher doses, right?
It does. It's quite unique in that respect. Niacin is a water-soluble B-complex vitamin. And while both niacin itself and its related compound, niacinamide, can function as vitamins after conversion to NAD or NADP in the body, only niacin itself affects lipid levels. And importantly, the hypolipidemic effects require significantly larger doses than those needed just for its vitamin functions.
So you need pharmacological doses, not just dietary intake. How does niacin work its magic on lipids? It seems to affect multiple things.
It really does have broad effects. In your adipose tissue, your fat stores, niacin inhibits the breakdown of triglycerides by an enzyme called hormone-sensitive lipase. This reduces the amount of free fatty acids being released and transported to your liver.
Less fuel for the liver to make triglycerides?
Exactly. And this, in turn, decreases the liver's own production of triglycerides. Niacin likely does this by stimulating a specific receptor on fat cells, GPR109A, which inhibits intracellular signaling. In the liver itself, niacin also appears to directly reduce triglyceride synthesis by inhibiting key enzymes involved in making fatty acids and putting them together into triglycerides. This also seems to increase the degradation of ApoB, further reducing the liver's output of VLDL.
So less VLDL production means less LDL eventually?
Correct. That reduction in hepatic VLDL production accounts for the subsequent reduction we see in LDL levels. Niacin also seems to enhance the activity of lipoprotein-like lipase, LPL, that enzyme we keep mentioning, which helps promote the clearance of chylomicrons and VLDL triglycerides from the blood.
And what about HDL? It's known for raising HDL quite effectively.
Yes, it's actually the most effective agent we have for raising HDL-C levels. It does this primarily by decreasing the fractional clearance or breakdown rate of ApoAI, the main protein in HDL. It slows down HDL removal rather than stimulating HDL synthesis.
So HDL sticks around longer, and LPA.
And uniquely, as you mentioned earlier, niacin is the only lipid-lowering drug currently available that significantly reduces LPA levels. The mechanism isn't fully understood, but it's a distinct effect.
So it has a really broad impact across the entire lipid spectrum. What about its various forms and how they're handled by the body? Are there different types of niacin?
Yes, there are different formulations, and this is important because they behave differently and have different side effect profiles. We have crystalline niacin, which is immediate release, IR. It dissolves quickly, gets absorbed almost completely, reaches peak levels in 30-60 minutes, but has a short half-life, meaning it needs to be dosed 2 or 3 times daily.
Okay, IR. What else?
Then there are various time-release or extended-release niacin preparations. These are designed to release the niacin more slowly, usually resulting in a peak level around 4 to 5 hours after dosing, allowing for once-daily administration, often at bedtime.
Are the over-the-counter flush-free versions effective?
That's a crucial point. There are non-prescription products marketed as flush-free niacin, often containing derivatives like inositol hexanocotonate or nicotinamide riboside. These are sold as dietary supplements. Because they are not FDA-approved drugs, they cannot legally claim to treat specific diseases like high cholesterol. They can only make general claims about supporting overall health. Critically, there have been reports of severe liver damage associated with unsupervised use of some non-prescription sustained-release niacin formulations. Patients should be very cautious with these and ideally only use prescription niacin under medical supervision for lipid lowering.
Very important warning. How is niacin metabolized?
At lower vitamin level doses, most niacin is taken up by the liver and converted to metabolites like nicotinic acid, which is excreted in the urine. At the higher pharmacological doses used for lipid lowering, a larger proportion of the unchanged niacin drug is excreted directly in the urine because the metabolic pathways get saturated.
Given all those mechanisms, what are its main therapeutic effects and where is it officially indicated?
Niacin is indicated for the treatment of hypertriglyceridemia and also for elevated LDL-C. In terms of efficacy, at therapeutic doses, it can reduce triglycerides by a substantial 35% to 50%, often as effectively as fibrates or statins, with the maximal effect seen within about a week. For LDL-C, it can achieve reductions of up to 25%, usually requiring higher doses like 4.56 grams a day and taking longer, maybe 3 to 6 weeks, to see the full effect.
And HDL.
As we said, it's the most effective agent for increasing HDL-C, often by 30% to 40%. However, its effect might be less pronounced in patients who start with very low HDL-C levels, say below 35 milli-GDL. But despite all these potentially beneficial effects on lipid numbers, it's really important to acknowledge that niacin's side effects significantly limit its widespread use in clinical practice today.
That's the big caveat. What are those compliance-limiting side effects, the ones that make people stop taking it? And are there ways to manage them?
The two main side effects that really limit patient compliance with niacin are flushing and dyspepsia or indigestion.
The flushing is famous or infamous.
It is. It's a cutaneous vasodilation, blood vessels in the skin widening, causing redness and warmth, typically of the face and upper body, often accompanied by itching, pruritus. It's primarily caused by the release of prostaglandins in the skin.
Can anything be done about it?
Yes. And here's a perhaps surprising but practical tip. Taking a regular aspirin, like 325 milligrams, about 30 minutes before each niacin dose can often significantly blunt or minimize this flushing.
Aspirin helps.
It does, by blocking prostaglandin synthesis. Flushing can also be minimized by starting with very low doses of niacin and gradually increasing them over weeks, and by taking the niacin dose after a meal. It's usually worse when therapy is first initiated or when the dosage is increased, but it typically subsides or becomes much more tolerable in most patients after 1 to 2 weeks on a stable dose. Patients should also avoid consuming hot beverages or alcohol right around the time they take their niacin, as this can definitely exacerbate the flushing.
What about the indigestion?
Dyspepsia, nausea, sometimes vomiting or diarrhea are also common. These are less likely if the drug is taken after a meal. Some patients also report dry skin, for which moisturizers can help, or a skin condition called acanthosis nigricans.
Are there any absolute contraindications or more medically serious potential side effects?
Yes, there are significant ones. Patients who have any history of peptic ulcer disease or who have active liver disease should not take niacin. Also, individuals who consume substantial quantities of alcohol should generally avoid it due to the increased risk of liver issues.
And the serious effects.
The most common medically serious side effects are hepatotoxicity, liver toxicity, usually seen as elevated serum transaminases, liver enzymes, and hyperglycemia, or high blood sugar. Both immediate-release and extended-release niacin have been reported to cause severe liver toxicity, particularly at doses above 2 grams per day, and perhaps more frequently with some older sustained-release formulations. Symptoms might include flu-like fatigue, weakness, loss of appetite, along with the lab changes.
And the blood sugar issue.
Niacin can induce insulin resistance and cause significant hyperglycemia, particularly in patients who already have diabetes. Diabetic patients starting niacin require very careful monitoring, at least weekly blood glucose checks, until their levels are stable, and their diabetes medications may need adjustment.
What about gout?
Niacin commonly elevates uric acid levels by inhibiting its excretion. and it can reactivate gout in susceptible individuals. So a history of gout is considered a relative contraindication for its use.
Any other rarer issues?
Yes, rarer but reversible side effects that have been reported include certain types of vision problems, toxic amblyopia, toxic maculopathy, and occasionally heart rhythm disturbances like atrial tachyarrhythmias or atrial fibrillation, particularly in the elderly. And importantly, niacin is contraindicated in pregnant women due to associated birth defects seen in animal studies.
Okay, so given all these concerns, especially the myopathy risk when combined with statins and the lack of proven outcome benefit as an add-on, how does niacin really fit into therapy now?
That's the critical question in modern practice. As we've emphasized, concurrent use of niacin and a statin can cause myopathy. And those two large randomized trials, AIM-HIH and HPS-2-THRIVE, specifically evaluating niacin as add-on therapy to a statin versus statin monotherapy, demonstrated no further reduction in ASCVD risk despite the improvements in lipid parameters.
Right, the outcomes didn't improve.
Correct. Given this lack of outcome benefit, the FDA in 2016 officially removed the indication for niacin use in addition to statin therapy for ASCVD risk reduction and withdrew approval for statin combination formulations containing niacin. So the bottom line today is that niacin could potentially still be considered as monotherapy in a carefully selected statin-intolerant patient, perhaps for managing very high triglycerides or attempting to raise very low HDL, but it's generally not recommended as an add-on therapy to statins for the purpose of further reducing ASCVD risk.
That really clarifies its current, much more limited role. Okay, that brings us to the fibric acid derivatives, or fibrates, like gemfibrozil and fenofibrate. How do these drugs work? What's their mechanism?
Fibrates exert many of their effects on blood lipids by interacting with special nuclear receptors called peroxisome proliferator activated receptors, specifically the alpha subtype, or PPRA. These PPRs essentially act as switches that regulate the transcription of various genes involved in lipid metabolism.
So they turn genes on or off?
In essence, yes. When fibrates bind to PPRA, they trigger several downstream effects that help produce triglycerides. This includes stimulating the enzymes involved in fatty acid oxidation, burning fat for energy, increasing the synthesis of lipoprotein lipase, LPL, and reducing the expression of a protein called ApoC3, which normally acts as an inhibitor of triglyceride breakdown.
So more LPL and less inhibition helps clear triglycerides faster.
Exactly. The increased LPL enhances the clearance of triglyceride-rich lipoproteins like VLDL and chylomicrons, and reducing ApoC3 production also helps clear VLDL more effectively.
How do they affect HDL?
The fibrate-mediated increases in HDL cholesterol are primarily due to PPRA stimulating the production of ApoAI and ApoA2, those key structural proteins of HDL. Interestingly, fenofibrate is generally considered more effective than gemfibrozil at increasing HDL-C levels.
Do they have other effects? Anti-clotting, maybe?
Yes, most fibrates also appear to have some potential antithrombotic effects, possibly by inhibiting coagulation factors and enhancing fibrinolysis, the process of breaking down clots. The clinical significance of these effects is still debated, though.
How are fibrates absorbed and eliminated from the body?
Fibrates are generally absorbed rapidly and quite efficiently, especially when taken with a meal absorption might be less efficient on an empty stomach. They reach peak plasma levels within about 1 to 4 hours.
Do they bind to proteins?
Yes, highly. More than 95% are bound to plasma proteins, almost exclusively albumin. Their half-lives vary significantly, from about 1.1 hours for gemfibrozil up to around 20 hours for fenofibrate.
Where do they go in the body?
They are widely distributed, with concentrations found in the liver, kidney, and intestine that actually exceed the levels found in plasma. They are predominantly excreted as inactive glucuronide conjugates, a form of processing by the liver in the urine, with a smaller amount eliminated in the feces. Excretion can be impaired in patients with renal failure. Gemfibrozil is known to cross the placenta.
What are their key therapeutic effects, and for whom are they usually considered the drug of choice?
The effects of fibrates on lipoprotein levels can actually vary quite widely. It depends a lot on the patient's baseline lipid profile, whether they have a specific genetic hyperlipoproteinemia, other environmental factors, and even which specific fibrate is used.
But are there patients who respond particularly well?
Yes, patients with a specific genetic condition called type 3 hyperlipoproteinemia, also known as dyslipidaemia, are often among the most sensitive responders. They can experience dramatic lowering of both triglyceride and cholesterol levels. Clinical improvements like regression of skin xanthomas, fatty deposits, and even improvement in angina or claudication symptoms have been reported.
What about more common, mild hypertriglyceridemia?
In patients with milder hypertriglyceridemia, say triglycerides below 400 mg/dl, fibrate treatment can typically decrease triglyceride levels by up to 50% and increase HDL-C concentrations by about 15%. The effect on LDL-C in these patients is more variable. It might be unchanged, or it could even increase slightly in some individuals.
And for severe hypertriglyceridemia, the pancreatitis risk group.
Yes, for patients with severe hypertriglyceridemia, often associated with a chylomicronemia syndrome, fibrates are usually considered the drugs of choice, specifically for preventing those dangerous episodes of pancreatitis. They work by both increasing triglyceride clearance via LPL and decreasing hepatic triglyceride synthesis. Maintenance therapy with a fibrate, along with strict dietary fat restriction and avoiding alcohol, helps keep triglyceride levels well below that critical 1,000 mg/dl threshold.
So they sound great for triglycerides, but again, the big question, what about ASCVD risk reduction when added to statins? Did they fare better than niacin?
Unfortunately, no. This is where we see a very similar outcome to niacin. A large, well-designed, randomized clinical trial, the ACCORD lipid study published in 2010, specifically looked at adding fenofibrate to background simvastatin therapy in patients with type 2 diabetes. The result: no further reduction of ASCVD risk was observed in the combination group compared to the statin-only group.
Another case of better numbers, but no better outcomes.
Exactly. And this finding directly led the FDA, again in 2016, to withdraw the indication or approval for using fenofibrate in addition to statin therapy, specifically for the purpose of ASCVD risk reduction. So like niacin, their primary role now is mainly focused on managing severe hypertriglyceridemia, not typically as an add-on for general ASCVD risk reduction if a statin is tolerated.
What about side effects and drug interactions for fibrates? Generally well tolerated.
Fibric acid compounds are usually well tolerated. The most common side effects tend to be gastrointestinal things like nausea, abdominal pain, diarrhea reported in up to 5% of patients. Other less common effects can include rash, urticaria hives, hair loss, myalgias, muscle aches, fatigue, headache, impotence, and sometimes anemia. Minor, usually reversible, increases in liver transaminases and alkaline phosphatase can also occur.
Any major drug interactions to watch for? Warfarin?
Yes, several fibrates, including clofibrate, bezafibrate, and fenofibrate, are known to potentiate the anti-gland action of warfarin. So patients on both drugs require very careful monitoring of their prothrombin time, or INR, and their warfarin dose may need to be significantly reduced.
And the myopathy risk with statins? You mentioned gemfibrozil was worse.
Correct. A myopathy syndrome, sometimes progressing to rhabdomyolysis, occasionally occurs with fibrate monotherapy, but the risk is significantly increased when fibrates are combined with statins. This risk appears to be highest with the combination of gemfibrozil and higher doses of statins, potentially affecting up to 5% of patients treated with this specific combination.
Why is gemfibrozil worse than fenofibrate in this regard?
The reason seems to be pharmacokinetic. Gemfibrozil significantly inhibits the hepatic uptake of statins via that OATP1B1 transporter, and it also competes with statins for the same glucuronidation enzymes needed for their inactivation and elimination. So the levels of both the statin and gemfibrozil may be elevated when they are co-administered, greatly increasing the muscle toxicity risk. Patients taking this combination need very close monitoring, including regular checks of CK levels. Even with lower doses of statins like rosuvastatin combined with fibrates, close follow-up is needed.
And fenofibrate is safer in combination.
It appears to be less likely to cause severe myopathy when combined with statins. Fenofibrate is glucuronidated by different enzymes that don't seem to interfere as much with statin metabolism. So while caution is always needed with any statin-fibrate combo, fenofibrate is generally considered the preferred fibrate if combination therapy is deemed absolutely necessary.
Any other risks or contraindications? Gallstones?
Yes, all fibrates increase the lithogenicity of bile, meaning they make the bile more likely to form gallstones. Clofibrate, an older fibrate not used much now, was clearly associated with increased gallstone formation. Therefore, gallbladder disease is generally considered a relative contraindication. Other relative contraindications include renal failure, as excretion is impaired, and significant hepatic dysfunction. And importantly, fibrates should generally not be used by children or pregnant women due to lack of safety data.
Okay. Now, let's move on to omega-3 fatty acid ethyl esters. These are often seen as supplements, fish oil capsules, but there are prescription versions too used for triglycerides. How do they work?
That's right. The active ingredients here are specific omega-3 fatty acids, primarily eicosapentaenoic acid, or EPA, and docosahexaenoic acid, or DHA, usually provided as ethyl esters in the prescription forms. They work mainly by reducing the liver's production and secretion of VLDL triglycerides. So they lower triglycerides. What's their main therapeutic use? They're used primarily as an adjunct to diet for the treatment of adult patients with severe hypertriglyceridemia, typically defined as triglyceride levels of 500 mg/dL or higher. The usual recommended daily oral dose for this indication is around 3 to 4 grams per day. A specific product, icosapent ethyl, which is a highly purified ethyl ester of just EPA, is also FDA approved as adjunctive therapy for these patients.
So we have common OTC fish oil supplements and these prescription products. What's the key distinction and what are the general recommendations around them?
It's a really important distinction. OTC fish oil supplements vary enormously in their actual content of EPA and DHA, their purity, and their dose per capsule. Quality control can be an issue. The American Heart Association for General Heart Health recommends that consumers simply eat a variety of fish, preferably oily fish, at least twice a week. They advise that fish oil supplements should only be considered for individuals who already have heart disease or very high triglyceride levels, and critically, only in consultation with a medical professional. They shouldn't just be taken casually for prevention by everyone.
And the prescription products.
In contrast, several prescription-only omega-3 products are available. These generally contain higher standardized doses of EPA and DHA and have undergone rigorous testing for efficacy and safety for specific indications. An important nuance here. Mixtures containing both EPA and DHA have actually been shown in some studies to potentially increase LDL-C levels in patients with severe hypertriglyceridemia, which might be undesirable. Studies of the EPA-only product, icosapent ethyl, have focused more specifically on reducing triglycerides and, more recently, cardiovascular events.
When should patients actually treat hypertriglyceridemia with these, given there seems to be some controversy?
There is indeed ongoing debate about exactly when to initiate pharmacological treatment for high triglycerides beyond lifestyle changes. It's absolutely essential that modifiable secondary causes like uncontrolled diabetes, excessive alcohol intake, certain medications, hypothyroidism are always addressed first. While the prescription omega-3 products generally have FDA indications for triglyceride levels of 500 mg/dL or greater, many professional organizations and experts actually advocate that pharmacologic treatment should primarily be limited to patients with levels of 1,000 mg/dL or greater.
Why the 1,000 threshold?
Because these individuals are at the highest risk for developing acute pancreatitis. Below that level, the pancreatitis risk is much lower, and the focus shifts more towards managing overall cardiovascular risk, where statins are typically primary.
This is where the clinical trial results sometimes seem conflicting, or at least confusing, especially regarding ASCVD risk reduction. Can you clarify the key trials and perhaps another one of those surprising results?
This is a critical area, and yes, it highlights a surprising evolution in our understanding, particularly around fish oil and heart protection. A large trial called the Origin trial, published back in 2012, looked at adding a modest dose, 1 gram day, of combined EPA-DA to standard care in patients with diabetes or prediabetes. It found no additional reduction in ASCVD risk associated with the omega-3 fatty acids compared to placebo, even though patients were often on background statin therapy.
So that cast doubt on general fish oil use for heart protection.
It certainly did. It called into question the widespread consumer use of lower-dose fish oil supplements for general heart protection. However, then came the REDUCE-IT trial, published in 2019, which generated a lot of buzz.
What did REDUCE-IT find?
REDUCE-IT studied a much higher dose, 4 grams per day, of the prescription, EPA-only product, icosapent ethyl, in patients who already had established cardiovascular disease or diabetes, plus other risk factors, were already on statins, but still had elevated triglycerides, roughly between 135 and 500 mg/dL. This trial showed a statistically significant decrease in major adverse cardiovascular events, including cardiovascular death, in the icosapent ethyl group compared to placebo.
Wow, so a positive result for that specific product in that specific population.
Exactly. A positive result, but in a very specific context. High dose, EPA only, in statin-treated patients with residual hypertriglyceridemia and high CV risk. This trial prompted organizations like the American Diabetes Association, ADA, to update their recommendations. They now suggest considering icosapent ethyl use in patients with diabetes and established ASCVD, or those with other CV risk factors who are on statin, have achieved their LDL-C goal, but still have elevated triglyceride levels between 135 and 499 mg/dL.
So it carved out a very specific niche based on that evidence.
Precisely. It highlights a very specific, evidence-based use case for icosapent ethyl, not a blanket recommendation for all fish oil.
How are these omega-3s handled by the body?
They're absorbed in the small intestine, Much of these absorbed fatty acids are oxidized, primarily in the liver, to provide energy. Their elimination half-life is quite long, approximately 50 to 80 hours.
What are the common adverse effects and potential drug interactions for omega-3 fatty acids?
Common adverse effects can include arthralgia, joint pain, nausea, the well-known eructation or fishy burps, dyspepsia, indigestion, and as we mentioned, potentially increased LDL-C levels, particularly with the DHA-containing forms. An important consideration is that omega-3 fatty acids may potentially prolong bleeding time slightly. So patients who are also taking anticoagulants or antiplatelet drugs should be monitored carefully for signs of bleeding. Icosapent ethyl specifically was also noted in trials to potentially increase the risk of atrial fibrillation or atrial flutter.
Okay. Now, for what many consider a major breakthrough in LDL receptor management, the PCSK9 inhibitors. This is a relatively newer class of injectable drugs, and they work by a completely different mechanism, targeting that PCSK9 protein we talked about earlier, doesn't it?
It does, absolutely. And it's a really fascinating story of how understanding human genetics directly led to a powerful new class of drugs. To really get PCSK9 inhibitors, you need to understand PCSK9 itself first.
Remind us what PCSK9 does.
Right. PCSK9 is a protein, a protease, mainly made by the liver. It circulates in the blood and binds to LDL receptors on the surface of liver cells. When PCSK9 binds to an LDL receptor, it essentially marks that receptor for destruction inside the cell, sending it to the lysosome to be degraded.
So more PCSK9 means fewer LDL receptors.
Exactly. More PCSK9 activity leads to fewer LDL receptors on the liver surface available to clear LDL from the blood, which results in higher plasma LDL-C concentrations.
And the genetic insights were key.
Invaluable. Researchers discovered individuals with natural genetic mutations that led to less functional PCSK9, loss of function. These people had significantly lower LDL-C levels throughout their lives and a markedly reduced risk of ASCVD. Conversely, other rare mutations lead to increased PCSK9 activity, gain of function, resulting in very high LDL-C levels and a much higher risk of ASCVD events, similar to FH. This genetic evidence strongly pointed to PCSK9 as a key regulator of LDL-C and a prime therapeutic target. There's a great diagram, figure 37-5 in our source, that shows this crucial mechanism.
So the goal became block PCSK9 to keep more LDL receptors working. What are the different types of inhibitors available now? How do they block it?
We have two main classes of PCSK9 inhibitors currently available. First, there are the monoclonal antibodies, or MABs. Examples are elorecumab and evolocumab.
Monoclonal antibodies, okay.
These are fully humanized antibodies, specifically designed proteins that essentially act like a biological shield. They circulate in the blood, bind very tightly to free PCSK9, and prevent it from ever attaching to the LDL receptor in the first place.
So they neutralize PCSK9.
Precisely. This leads to significantly less degradation of the LDL receptor, meaning more receptors remain active on the liver cell surface, which greatly increases the liver's capacity to clear LDL from the circulation, thereby dramatically lowering serum LDL-C levels.
And the second class is different.
Yes. The second class, represented by inclisiran, approved more recently in 2021, uses a completely different technology. Inclisiran is a small interfering ribonucleic acid, or siRNA therapeutic.
siRNA gene silencing.
Kind of. It's designed to specifically target the messenger RNA, mRNA, molecule that carries the instructions for making the PCSK9 protein inside the liver cell. By intercepting and degrading this mRNA, inclisiran effectively blocks the synthesis of the PCSK9 protein before it's even made.
So antibodies mop it up outside the cell, siRNA stops it being made inside the cell, two different approaches.
Exactly. Pooled clinical trial data for inclisiran show that it can lead to really significant and notably persistent reductions in both PCSK9 levels and LDL-C. This long duration of action suggests a very infrequent dosing regimen, like maybe just twice a year or potentially even once a year in the future, might be viable.
That sounds incredibly potent and convenient. How do these therapeutic effects play out, especially when used alongside statins? Are they complementary?
Highly complementary. Think of it this way. Statins work inside the liver cell to inhibit cholesterol production and also stimulate the production of more LDL receptors. PCSK9 inhibitors work, either outside or inside, depending on the type, to ensure that more of those LDL receptors, whether newly made or existing, actually remain available on the liver cell surface by preventing their destruction.
So they work synergistically.
Absolutely. The synergy makes them very powerful LDL-lowering agents. The PCSK9 monoclonal antibodies can reduce LDL-C in a dose-dependent manner by as much as 70% when used as monotherapy, or by as much as 60% even in patients who are already taking statin therapy. That's a huge additional reduction.
What are they officially approved for?
They have several FDA approvals. They're approved to lower the risk of myocardial infarction, heart attack, stroke, and unstable angina, requiring hospitalization in patients who already have established cardiovascular disease. They're also approved as adjunctive therapy, meaning added on for lowering LDL-C in adults with both heterozygous, HeFH, and homozygous, HeOFH, familial hypercholesterolemia, who often need very aggressive LDL lowering.
Are they used for statin intolerance?
It's important to note they're not officially FDA approved specifically for statin-intolerant patients without known ASCVD in the U.S., although they are sometimes used off-label in this population in other parts of the world or in specific clinical situations.
And what about their cost versus their effectiveness? That seems like a major discussion point for such potent, newer drugs.
It is a very significant consideration. Given the substantially higher cost of treatment with PCSK9 inhibitors compared to a relatively inexpensive generic statin therapy, numerous published cost-effectiveness analyses have generally concluded that these medications are only considered cost-effective in very specific, very high-risk patient populations.
So not for everyone with high cholesterol.
Definitely not. Because of these cost-effectiveness analyses, current guidelines and practice generally recommend that treatment with maximally tolerated doses of statins, often combined with ezetimibe first, should be optimized before considering initiating PCSK9 inhibitors. They are typically reserved for those at highest residual risk, despite optimal standard therapy.
But do they improve outcomes?
Yes. Large clinical outcomes trials, like the 4-year trial with evolocumab and the Odyssey outcomes trial with elercumab, did show that these agents, when added to statins in patients with established ASCVD and elevated LDL-C, further reduced the rate of major cardiovascular events, like heart attacks and strokes, although they did not show a statistically significant reduction in overall mortality or cardiovascular death in those specific trials.
Okay, so event reduction, but not necessarily living longer in those studies. How are these powerful drugs administered, and what about their practical use, storage, monitoring?
Right. All currently available PCSK9 inhibitors are administered as subcutaneous injections, meaning an injection just under the skin, usually self-administered by the patient after training. The monoclonal antibodies, alirocumab and evolocumab, are typically given either every 2 weeks or once monthly, depending on the specific dose and indication. Inclisiran, the SIRA, has that unique, much less frequent dosing regimen. An initial dose, then another dose after 3 months, and then subsequent doses only every 6 months thereafter. That biannual dosing could be a major advantage for adherence.
And storage?
The antibodies usually require refrigeration, although they can be kept at room temperature for a limited time before use. Inclisiran has the practical advantage of being able to be stored at room temperature.
How soon can you check if they're working?
LDL-C plasma levels can be measured typically about 4 to 8 weeks after starting antibody therapy or changing doses to assess the response. The antibodies inhibit PCSK9 activity for about 2-3 weeks after injection, and their half-lives are around 11-20 days. For inclisiran, studies showed it reduced PCSK9 levels by about 75% at 4 months and maintained significant reduction at 6 months, leading to LDL-C reductions of around 53% at 6 months after a single dose in some studies.
Do dosages need adjusting for kidney or liver problems?
Generally, no dosage adjustments are required for the monoclonal antibodies in patients with mild kidney impairment. For inclisiran, no adjustment is needed for mild to severe renal impairment or mild to moderate liver impairment. However, data is limited for severe impairment for all agents.
And pregnancy lactation, still a no-go.
Yes. PCSK9 inhibitors should not be used during pregnancy. As antibodies, they are expected to cross a placenta, and potential effects on the fetus are unknown. Similarly, it's unknown if they pass into breast milk, so use during lactation is also not recommended.
What about adverse effects and drug interactions? Are there similar concerns to statins, like muscle problems?
This is where PCSK9 inhibitors really stand out, actually. Some clinical trials identified a small potential risk, maybe less than 1%, of neurocognitive effects like memory issues or confusion in patients treated with the PCSK9 antibody inhibitors compared to placebo. Ongoing studies are still looking into the long-term implications, if any.
But what about myopathy?
Critically, unlike many other lipid-lowering medications, PCSK9 inhibitors do not appear to substantially increase the risk of myopathy or other muscle-related problems, either when used alone or when added in combination with statins. This is a major advantage, especially for patients who struggle with statin-induced muscle symptoms.
That's huge. Any other side effects?
Similar to other monoclonal antibody therapies, there might be a slightly increased risk of infections, typically mild ones like nasopharyngitis, common cold, urinary tract infections, or upper respiratory infections. Injection site reactions like redness, itching, or swelling at the injection spot are the most frequent adverse effect reported for both the antibodies and inclisiran, but these usually occur in less than 10% of patients and are generally mild and transient.
And drug interactions.
Another significant advantage. There are currently no known significant drug interactions with PCSK9 inhibitors. This simplifies their use considerably compared to statins or fibrates.
Okay, that's a comprehensive look at PCSK9 inhibitors. Now, let's tap on a couple of other, perhaps more niche non-statin therapies. First, limidipide, which is an inhibitor of microsomal triglyceride transfer protein, or MTP. This sounds like a very specific mechanism targeting lipoprotein assembly.
It is very specific. Limidipide was the first drug developed to inhibit MTP. As we discussed way back when talking about VLDL and chylomicrons, MTP is absolutely essential for loading triglycerides onto ApoB proteins inside liver and intestinal cells, which is a necessary step for forming and secreting VLDLs and chylomicrons.
So limidipide blocks that loading process.
Exactly. By inhibiting MTP, limidipide effectively blocks the assembly and release of these ApoB-containing lipoproteins, VLDLs from the liver, and chylomicrons from the intestine.
And what are its therapeutic uses and effects? Who gets this drug?
Limidipide is FDA approved, but only as an adjunct to diet and other lipid-lowering therapies for lowering LDL-C, total cholesterol, ApoB, and non-HDL cholesterol, specifically in patients with homozygous familial hypercholesterolemia. HoFH.
Only for HoF.
Yes, that very rare and severe inherited form. It's not for general cholesterol lowering. In LFH patients, it can reduce LDL-C levels by up to 50% on top of whatever else they're taking, like maximally tolerated statins. The dosing starts low, 5 mg a day, and is gradually titrated up to a maximum of 60 mg daily based on response and tolerability. However, it's important to note that the long-term effects of limidipide on actual cardiovascular outcomes are currently unknown.
How is it administered, and what are its major adverse effects and drug interactions? It sounds like it might have some significant ones given its mechanism.
It's administered orally, once daily, with water, and importantly, without food, or at least 2 hours after the evening meal. This timing is recommended to help reduce the gastrointestinal side effects. It is metabolized by the CYP3A4 enzyme system, so it is contraindicated for use with strong inhibitors of CYP3A4, as that would dangerously increase limidipide levels.
And the side effects, GI issues.
Yes. Significant GI side effects are very common, reported in most patients in clinical trials. These frequently include diarrhea, nausea, vomiting, and abdominal pain or cramping. Adhering to a strict low-fat diet, less than 20% of calories from fat, is essential and may help improve tolerability somewhat.
What about liver toxicity? Blocking fat transport sounds risky for the liver.
That is the major concern. There are serious concerns regarding hepatotoxicity and hepatic steatosis, fatty liver, with limidipide. In clinical trials, about 1/3 of patients experienced elevations in liver enzymes, ALT or AST, greater than 3 times the upper limit of normal, indicating liver stress or injury. It also consistently increases the amount of fat stored in the liver, which can happen with or without the transaminase elevations.
So it requires careful monitoring.
Extremely careful. Due to this concerning side effect profile, particularly the risk to the liver, limidipide is only available and used under a strict FDA risk evaluation and mitigation strategy, or REMS program. This involves specific prescribing requirements, patient counseling, and regular liver function monitoring.
Any other major warnings?
Yes. Based on animal studies, limidipide may be embryotoxic, meaning harmful to a developing fetus. Therefore, women of childbearing potential must have a negative pregnancy test before starting treatment and must use effective contraception throughout the duration of therapy.
Okay, definitely a specialized drug for a specific high-risk population with significant safety considerations. Moving on to another relatively new class, the ATP citrate lyase, or ACL inhibitor, specifically bempedoic acid. This was approved in 2020. How does this one fit into the cholesterol-lowering landscape?
Right. Bempedoic acid represents a new class of oral cholesterol-lowering drugs. It works by inhibiting cholesterol synthesis in the liver, similar in concept to statins, but it targets a different enzyme earlier in the same pathway. Its mechanism is complementary to both statins and ezetimibe.
What's it approved for?
It's FDA approved as an adjunct to diet and maximally tolerated statin therapy to achieve further LDL-C lowering in patients with heterozygous familial hypercholesterolemia, FH, or patients with established ASCVD who need additional LDL reduction. It also has a potential application in patients who are genuinely statin intolerant. A fixed-dose combination tablet containing both bempedoic acid and ezetimibe, is also approved.
So how does it inhibit cholesterol synthesis? What enzyme does it target?
Bempedoic acid itself is actually a prodrug. It's inactive when swallowed. It needs to be activated within liver cells by a specific enzyme, very long-chain acyl-CoA synthase 1, into its active form, bempedoic acid-CoA.
Okay, activated in the liver. Then what?
This active form then competitively inhibits ADP citrate lyase, or ACL. ACL is a cytoplasmic enzyme that acts upstream of HMG-CoA reductase, the statin target. It's responsible for converting citrate into acetyl-CoA, which is a key building block needed for both cholesterol and fatty acid synthesis.
So it cuts off the supply of building blocks earlier in the chain.
Exactly. By inhibiting ACL, bempedoic acid reduces the flow of acetyl-CoA into the cholesterol synthesis pathway, ultimately leading to reduced de novo hepatic cholesterol synthesis. Because it acts at a different step than statins, its cholesterol-lowering effects are generally additive with those of statins.
Does it affect LDL receptors too?
Yes, similar to statins, the resulting reduction in intrahepatic cholesterol levels leads to an upregulation of LDL receptors on the liver cell surface, further enhancing LDL-C clearance from the blood.
What about its efficacy? How much does it lower LDL-C?
As monotherapy, bempedoic acid typically results in about a 15% to 25% reduction in LDL-C, which is generally less potent than most statins. However, when used in combination with ezetimibe, the LDL-C reduction is around 30%. And in triple therapy with a maximally tolerated statin plus ezetimibe, it can contribute to overall LDL-C reductions reaching up to 65% in some studies. Interestingly, it also typically causes a small reduction in HDL-C, around 5%.
How is it handled by the body? ADME.
It's administered orally, usually once daily, as a 180 milligram tablet. Both the prodrug and its active metabolite are eventually inactivated, primarily by glucuronidation via an enzyme called UGTTB7, and the resulting conjugates are mainly excreted in the urine, about 70%, partly via a renal transporter called OAT2. It can weakly inhibit some other OAT transporters. Its elimination half-life is reasonably long, around 21 hours, and it reaches steady-state levels in the blood within about 7 days.
What are the main adverse effects and drug interactions to be aware of?
One notable adverse effect associated with bempedoic acid is hyperuricemia, an increase in uric acid levels in the blood. This is thought to be due to competition with uric acid for that renal transporter OAT2, reducing uric acid excretion. This increased uric acid can, in turn, increase the risk of developing gout in susceptible individuals.
Okay, gout risk. Anything else?
Other potential adverse effects reported, though less common, include tendon ruptures, similar to a rare risk seen with statins, and increases in serum creatine kinase, CK, creatinine, and hepatic transaminases.
Any important drug interactions, especially with statins?
Yes. Crucially, due to a potential increased risk of myopathy when combined, bempedoic acid is generally not recommended for use with simvastatin doses greater than 20 milligrams per day, or with pravastatin doses greater than 40 milligrams per day. Correction from outline. Interaction is with simvastatin 20 milligrams and pravastatin 40 milligrams, not rosuvastatin.
Good to know those dose limits. What about pregnancy?
Because it inhibits an enzyme essential for cholesterol synthesis, which is vital for fetal development, bempedoic acid may cause harm to the fetus and is contraindicated during pregnancy.
Okay. Finally, let's look at a very recent approval in this space, the inhibitor of angiopoietin-like protein 3, or ANGPTL3, evinacumab-GGMB. This is another monoclonal antibody, right? What's the mechanism here? What does ANGPTL3 do?
Yes, evinacumab is another recombinant human monoclonal antibody. It works by binding to and inhibiting a protein called angiopoietin-like protein 3, or ANGPTL3. ANGPTL3 is a protein primarily expressed in the liver that plays a key role in regulating lipid metabolism, mainly by acting as a natural inhibitor of two important enzymes, lipoprotein lipase, LPL, and endothelial lipase, EL.
So ANGPTL3 normally puts the brakes on LPL and EL.
Exactly. By inhibiting ANGPTL3, evinacumab essentially releases the brakes on LPL and EL.
And how does that lower lipids? It seems to affect LDL differently than PCSK9 inhibitors.
It does. The inhibition of ANGPTL3 leads to reduced LDL-C levels, but interestingly, this effect appears to be independent of the presence or function of the LDL receptor. It's thought to work primarily by promoting the processing and clearance of the LDL particles upstream of LDL formation, likely due to the enhanced LPL activity.
So it can work even if LDL receptors aren't fully functional.
That seems to be the key advantage, yes. It also lowers triglyceride levels by boosting LPL activity, and unlike many other LDL-lowering drugs, it also tends to lower HDL-C levels, likely by boosting the activity of endothelial lipase, EL, which metabolizes HDL.
Who is this drug approved for? Still HoFH?
Yes, currently, ezetimibe is approved by the FDA, again, only as an add-on treatment to other lipid-lowering medications and diet for patients aged 12 years and older with homozygous familial hypercholesterolemia, HoFH. Its safety and effectiveness have not been established in patients with other forms of hypercholesterolemia, including the more common HFH.
How effective is it in HFH?
In a key clinical trial involving HoFH patients who were already on background lipid-lowering therapies, adding ezetimibe resulted in an average reduction in LDL-C of nearly 50% after 24 weeks compared to placebo. That's a very significant additional lowering in this extremely difficult-to-treat population.
How is it administered, and what about its ADME?
The recommended dose is 15 milligrams per kilogram of body weight, administered as an intravenous IV infusion over 60 minutes every 4 weeks.
IV infusion, okay, not subcutaneous. How is it metabolized?
Its exact metabolic pathway hasn't been fully characterized, but as a human monoclonal IgG4 antibody, it's expected to be degraded into smaller peptides and amino acids through normal protein catabolism pathways, just like the body's own endogenous IgG antibodies. Its elimination half-life isn't constant, but serum concentrations typically decrease below the limit of detection about 19 weeks after the last steady-state dose.
What are the major adverse effects and potential interactions?
The major warnings associated with ezetimibe include the potential for serious hypersensitivity reactions during or after the infusion and potential embryo-fetal toxicity based on animal studies. Therefore, it is contraindicated during pregnancy and should be used with caution in patients with a history of allergies to ezetimibe or its components.
What are the more common reactions?
Common adverse reactions reported in trials include things like nasopharyngitis, common cold symptoms, influenza-like illness, dizziness, rhinorrhea, runny nose, and nausea.
Any known drug interactions?
Currently, there are no documented significant drug interactions with ezetimibe.
Okay, that covers an incredible amount of ground on current therapies. We've journeyed through this vast landscape of dyslipidemia, from its fundamental biology and that intricate dance of lipoproteins to the evolving treatment guidelines, and this really impressive, sometimes astounding array of pharmacological interventions now available. But medicine is always evolving. What's on the horizon? What future developments are shaping the management of dyslipidemia?
It's a great question because the field is definitely not standing still. One area of profound impact and ongoing development is deepening our understanding, particularly of familial hypercholesterolemia, or FH.
The inherited form again.
Right. As we've discussed, FH is the most common inherited cardiovascular disease, and it's associated with significant morbidity and sadly reduced life expectancy if not managed well. For many years now, our understanding of those inherited mutations in specific genes that are critical for normal LDL receptor function and catabolism genes like LDLR itself and PCSK9 has provided absolutely invaluable insights.
And led directly to drugs.
Directly. This knowledge has directly fueled the invention of drugs, like statins initially, and more recently PCSK9 inhibitors and others that specifically target these pathogenic steps. These therapies help to restore, at least in part, more normal levels of LDL-C and have significantly reduced the cardiovascular risk for individuals carrying these specific mutated genes. It's really a powerful example of how understanding the underlying genetics translates directly into life-changing therapies.
That's a clear success story of bench-to-bedside research. What about the concept you mentioned earlier, polygenic risk scores? That sounds like a really exciting new frontier in personalized prevention, moving beyond single-gene mutations.
It absolutely is, and it holds tremendous potential. Beyond those relatively rare single-gene causes of severe FH, evidence emerging from large-scale genetic studies like whole exome sequencing studies has clearly demonstrated that high cholesterol levels and the associated cardiovascular risks can also be caused by the combined aggregate effects of many common small-effect genetic variations or alleles.
So lots of small genetic factors adding up.
Exactly. It's not just one faulty gene, but the cumulative impact of maybe dozens or even hundreds of tiny genetic influences across the genome. This exciting discovery is opening the door to developing and validating these polygenic risk scores.
And the potential is predicting risk much earlier.
That's the incredible hope. The predictive potential here is immense. These scores could theoretically predict an individual's predisposition to high cholesterol and subsequent cardiovascular risk well before clinical signs, such as overtly abnormal LDL-C levels, are even measurable, perhaps even from a young age. Imagine identifying someone's lifelong inherent risk decades earlier than we can now, based just on traditional risk factors.
So we could identify risk even earlier than ever before. What are the potential downstream benefits of being able to do that?
The potential future benefits are really substantial. Imagine being able to initiate appropriate primary prevention therapy, maybe lifestyle advice, maybe medication if indicated by the risk score based on genetic analysis at a very early age, for patients identified as having high polygenic risk for FH or ASCVD. This could significantly reduce their lifetime cumulative exposure to risk factors and potentially prevent or significantly delay premature atherosclerotic disease.
Preventing disease before it even starts?
That's the goal. Moreover, expanding the use of cascade screening not just for single gene mutations, but potentially using polygenic scores to identify relatives at increased risk could dramatically increase the population-level benefits of genetic testing.
Could it lead to new drugs, too?
Potentially, yes. Detailed analysis of which specific genes or combinations of genes contribute most significantly to disease risk in specific patient populations might also identify novel biological pathways and potential new drug targets that wouldn't otherwise be discovered through traditional research methods.
And maybe help use current drugs better.
Yes, even in the nearer term, there could be benefits. For example, polygenic risk information might help offset the costs of genetic sequencing by reducing the inappropriate use of very expensive therapies, like monoclonal antibodies, in patients who might not derive as much benefit, while helping to rapidly optimize therapy in those identified as being at extremely high genetic risk. It's really about getting the right treatment intensity to the right person at the right time, informed by their unique genetic makeup.
That sounds incredibly promising, a potential revolution in personalized cardiovascular medicine. But I imagine there are significant challenges or hurdles to actually implementing this kind of widespread polygenic risk scoring in routine clinical practice.
Indeed. While the potential is exciting, there are definitely crucial hurdles that need to be overcome for wide-scale adoption. These include achieving broad clinicians and payer acceptance and understanding of how to interpret and act on these scores. There's the current cost of comprehensive genetic sequencing, although that's coming down, significant privacy and ethical concerns surrounding the use and storage of personal genetic results need careful management.
And ensuring the scores are accurate for everyone.
Absolutely critical. There's a major need to develop and validate accurate risk algorithms that work well across genetically diverse populations, ensuring they don't exacerbate health disparities. And finally, there's the challenge of ensuring the appropriate application of these risk scores by clinicians in practice so they lead to optimal evidence-based therapeutic management decisions, not just generating a number. It's a complex interplay of rapidly advancing science, clinical translation, ethics, and healthcare system infrastructure. But the potential is undeniable, and it's certainly a field that's evolving very quickly.
And that brings us, I think, to the end of another very deep dive. We've really journeyed through the intricate world of dyslipidemia today. From its basic biological underpinnings and that delicate, complex dance of lipoproteins,
All those acronyms.
to the evolving landscape of treatment guidelines, and this truly impressive, sometimes quite astounding array of pharmacological interventions now available. It really shows how our understanding is constantly evolving, driven by scientific discovery and clinical need, allowing us, hopefully, to get closer to truly mastering this information.
Yeah, and our aim throughout this deep dive was really to equip you, our listener, with a robust foundational understanding, trying to transform what can definitely feel like complex medical jargon into knowledge that's more accessible, maybe even actionable in conversations with your own doctor. We hope you now feel much more well-informed, ready to understand this important topic, almost like, well, like one of those elite professionals in the field.
So, as we wrap up, here's a final thought to leave you with. As we consider this incredibly complex interplay of our genetics, our lifestyle choices, and this cutting-edge pharmacology we've discussed, what aspect of the future of cardiovascular disease prevention, maybe polygenic risk, maybe new drug targets, maybe something else entirely do you find most compelling or perhaps most concerning? And what questions does it raise for you personally?
Definitely something to ponder. Thank you for joining us on this deep dive today.
Indeed. Until next time, stay curious.